5 Navy SEALs were dying inside the most advanced trauma center on the West Coast, and every single monitor said they were fine. The doctors were laughing at the woman, trying to save them. She didn't argue. She didn't raise her voice. She moved to the first bed, pulled back the patient's eyelid with 2 fingers, and said quietly to no one in particular, "He has 4 hours, maybe less." The room went silent, not because they believed her, because none of them had thought to check. The woman they'd spent 3 months dismissing as a rookie, a nobody, had just seen something every board-certified physician in that room had missed, and that was only the beginning. If you're new here, welcome. Hit that subscribe button right now, because this channel is where ordinary-looking people turn out to be anything but. Drop a like on this video, and tell me in the comments what city or country you're watching from. I want to see exactly how far this story has traveled. Now, stay with me, because what happens next inside this trauma bay is going to change everything you think you know about who deserves to be heard. The morning shift at Harlow Memorial Trauma Center started the way it always did in the Pacific Northwest gray light, through rain-streaked windows, the smell of recycled air, an antiseptic, and Dr. Marcus Velt moving through the department like a man who'd already decided how the day would go before he'd finished his first coffee. Velt was chief of trauma, 42 years old, 12 years at Harlow, 3 commendations from the hospital board, and a framed photo of himself with a state congresswoman hanging in his office beside his certifications. He had the kind of confidence that came from never having been seriously wrong in front of anyone who outranked him. His residents admired him. His nurses worked around him. His patients recovered at an acceptable rate, and he had learned, over the years, to attribute that to his own judgment rather than the quiet, consistent work of the people beneath him in the hierarchy. He had never once asked a nurse what she thought about a clinical picture. Not because he was cruel about it, he wasn't, particularly, but because it simply hadn't occurred to him that there was a reason to. Claire Dawes had been at Harlow for 11 weeks. She was 34, which was older than the other new nurses on the floor, and that discrepancy alone made people fill in a story about her. Late start, community college detour, maybe personal issues that had slowed her down. The second-year residents called her the late bloomer in the break room. Not with active malice, but with the casual thoughtlessness of people who have never had to fight to be taken seriously. She was quiet. She moved through the department without friction or announcement. She did her work correctly, asked targeted questions when she had them, and declined to perform the kind of enthusiasm that might make people feel better about having her around. She wore her hair pulled back tight. She kept her sleeves down, even on warm days. She had a wristwatch, old, analog, with a cracked crystal and a NATO strap that she wore on her left wrist under her sleeve, and no one had ever seen her take it off. Her credentials were real and unremarkable. BSN from a state university, trauma nursing certification, clean employment history, starting from 2 years prior. Nothing before that in the official record. No gaps flagged, because the record simply began where it began. And no one at Harlow had looked closely enough to wonder why a 34-year-old's professional history started at 32. That was, as it turned out, exactly how she had intended it. She was at the medication station at 7:14 updating chart notes with the focused efficiency of someone who had learned to do several things simultaneously in environments where distraction was not an option when the radio traffic started changing. She didn't hear the content, she was too far from the dispatch desk, but she heard the frequency of it shift. The way a room's acoustics change when something important is incoming. Paused her stylus over the tablet for just a moment. Then she finished her notation, set down the tablet, and walked to the supply cart near Trauma Bay 2. She was restocking the cart when the overhead announcement came through at 7:19. 5 adult male patients, military personnel, inbound via emergency transport from the coastal highway. Nature of injuries, undetermined. Mechanism listed as offshore industrial accident. 6 minutes. Velt was already at the central station, pulling on gloves. Around him, Residents materialized from their various corners of the department. Perry Okafor, second year, who was competent and eager and desperately wanted Velt to know it, doctor. Simone Farfar, a third year, who was technically the better clinician of the two and knew better than to make that obvious, and two interns who had the expressions of people who had not yet decided whether this was exciting or terrifying. Claire approached the station. Do we have any additional details on mechanism? Industrial accident at sea could mean we don't need the editorial. Dawes. Velt was reviewing the prelim intake sheet without looking up. Go prep Bay 4. Actually prep all 5 bays. We're getting a full set. I can assist with triage assessment when they arrive. I have a background in. You can assist by making sure the IV lines are primed and the carts are stocked. He handed the intake sheet to Okafor. Perry, your primary, on whatever comes through first. Farrar, take 2 and 3. Let's move. Claire said nothing. She went to Bay 4, checked the crash cart, primed the IV line, confirmed the suction equipment was functional and positioned correctly, calibrated the monitoring leads. Then she moved to Bay 1 and did the same thing. Then 2, then 3, then 5. She was finishing Bay 5 when Velt passed behind her. Stopped. I told you Bay 4. They're all prepped, she said. He looked at her. Not with appreciation, and not quite with irritation, with the particular blankness of a man who doesn't know how to process efficiency that wasn't his idea. He turned and walked away. The ambulances pulled into the bay at 7:26 a.m. The first thing Claire registered was not the patients. It was the smell present the moment the ambulance doors opened before the paramedics had finished their transfer handoff. Faint, but specific. Metallic at the front, and underneath that something chemical, with an almost industrial bitterness that didn't belong on a person who'd been working at sea. Caught it and filed it without breaking stride, the way you file a sound you've heard before in a place you don't talk about in public. 5 patients came in fast and loud, all large, all clearly physically capable under normal circumstances, all in various states of reduced capacity now. The paramedics delivered their handoff reports efficiently, blood pressure within normal limits across all 5, heart rates elevated but not critically, oxygen saturation holding at acceptable levels. From a numbers perspective, these were not men who appeared to be in immediate danger. From where Claire was standing, that was precisely the problem. She positioned herself at the edge of Bay 1, where the first patient was being transferred. 38 years old, no name in the system yet, built like someone whose fitness was functional rather than aesthetic. His vitals were unremarkable. His skin color was slightly pale but not shocky. He was answering the paramedics' orientation questions with single words, pupils tracking correctly. But his breathing was wrong. Not wrong enough to alarm a monitor. Not wrong enough to make a resident pause mid-motion and look. The rhythm was slightly off, a barely perceptible compensatory effort in the accessory muscles along his neck and upper chest, the kind of subclinical labor that showed up when the body was starting to work harder than it wanted to admit. You would only recognize it if you had watched men breathe in environments where every breath was earned rather than assumed. Claire had watched that for years, in places she was not going to mention in this emergency bay. She moved to his bedside. Can you tell me where you feel the most discomfort right now? He looked at her with the flat calculating assessment of a man whose professional life involved rapidly deciding who was useful and who wasn't. Left side, he said. Chest and below. It's dull. Came on slower than the rest of it. When did it start? 50 minutes ago. Did it start or after the accident? A beat after. She pressed lightly on his left flank. He didn't react, and that was wrong in the other direction. A man with any significant trauma to that region should have given her at least a flinch. The absence of pain response, layered over the abnormal breathing pattern, layered over the faint smell she'd caught at the door, layered over a blood pressure reading that was technically normal, but had ticked down 2 points between the paramedic's reading and the current monitor display. I want to flag this patient for fast exam and abdominal CT she said, directing it toward Okafor, who was moving past the bay entrance. I'm seeing possible indicators of internal. Vitals are stable, Okafor said, barely slowing. We'll get to imaging in order once everyone's assessed. His pressure has dropped 4 points since arrival. That's a trend, not a variation. 4 points is within normal drift. Let the machine do its job. He kept moving. She looked at the patient. He was still watching her with that flat, level expression. I'm going to stay near, she said quietly. Tell me if the chest feeling changes, specifically if it gets harder to take a full breath. He held her gaze for a moment. Then he gave one small nod, the nod of a man who has learned to distinguish between people performing competence and people who actually have it. By 7:48 a.m., all 5 patients were settled in their bays and had received visual assessments from Velt and his residents. Labs were drawn, imaging was cued, and the official clinical picture was 5 military patients, stable condition, mechanism unclear, management pending diagnostics. Velt stood at the central monitoring station with coffee and measured authority, watching the readouts with the comfort of a man who has seen worse and survived. Claire moved between bays. She was not assigned to do this. Her patient was in Bay 4, a 32-year-old with a sutured forearm laceration and a complaint of headache, the least dramatic presentation of the 5 on paper. Spent 6 minutes doing her formal assessment of him, documented everything correctly, and then began quietly moving through the other bays in the intervals between assigned tasks, using the cover of routine supply checks and vital confirmations. Bay 2, the patient there was compensating for reduced lung capacity. His oxygen saturation was 96%, which looked fine, but his respiratory rate had climbed by 2 breaths per minute since arrival. He was doing the work consciously. She could tell deliberate. Slow breaths, the kind of breathing you do when your body's instinct is to breathe faster, but you've been trained to override panic. He was buying himself time. The question was how much. Bay 3, the quietest of the 5. 29 years old, barely spoke during assessment, answered every question with minimal words. His numbers were the most normal of any of them. But his lips had a color that was slightly off, not cyanotic, not the blue-gray of oxygen deprivation, something different and harder to name. A flatness to the pigmentation. And when she asked him to follow her finger, his tracking was smooth, but there was a micro-hesitation on the leftward sweep that didn't belong there. Bay 4, her assigned patient, the tracking hesitation was present there too, slightly more pronounced. The headache he'd reported as a 7 was the thing that concerned her, not the number, the quality. He'd described it as pressure behind the eyes, like something pushing outward. That specific description, combined with the tracking lag, was not a concussion headache. Bay 5, the one that scared her most. He was the oldest of the group, mid-40s, the only one who had not reported any complaint during intake. He had declined pain medication twice. His vitals were the best of all 5. He was sitting up when she entered, arms crossed, watching the trauma bay with the patient, cataloging attention of a man accustomed to being in unfamiliar environments and needing to understand them quickly. I'm just doing a check, she said. You've already been to the other 4, he said. She didn't confirm or deny. She took his blood pressure manually, counted his respirations, checked his capillary refill, looked at his eyes. Everything within normal range. And then she waited, watching his hands where they rested on his crossed arms. And after approximately 40 seconds, she saw it. A fine tremor in the fingers of his right hand, lasting about 3 seconds, then stopping. He noticed her watching, and his hand stilled, deliberately. How long has that been happening? She asked. Intermittently, he said, since the transport. Bilateral? A pause, mostly right. She wrote it down. He watched her write it down with an expression that was difficult to read, not quite relief, not quite concern. Something closer to the recognition of being seen accurately. I'm going to document this and make sure your physician knows, she said. Will they listen? She met his eyes briefly. I'm working on that. 8:03 a.m., the monitor in Bay 2 alarmed. Oxygen saturation had dropped to 93%. Okafor responded within 90 seconds, assessed correctly, called a probable tension pneumothorax, and initiated chest decompression. The Bay became controlled, loud, fast-moving for the next 7 minutes. When it resolved, the patient was stabilized with a chest drain in place, and the immediate crisis was over. Velt appeared in the doorway at the 4-minute mark to supervise. When the last step was complete, he put a hand briefly on Okafor's shoulder. "Good catch, Perry." Claire had handed Okafor the chest drain kit before he finished asking for it. She had also repositioned the suction line when his first angle wasn't giving him access, and she had monitored the patient's blood pressure manually throughout because the automated cuff had been knocked loose in the initial movement and no one had noticed. No one said anything to her. She went back to the nurse's station and updated her documentation. Typed, she pulled up the shared lab queue and scanned for patient 1's results, which were still pending. Then she scanned the other 4. She was looking for the toxicology markers. Specifically, the full panel wouldn't be back for another hour at least, but the preliminary was flagged in patient 1's chart. She opened it. The preliminary showed 1 elevated marker. The value was listed with a footnote from the lab. Possible contaminant. Recommend repeat draw. It was the kind of footnote that encouraged physicians to dismiss the result and wait for the full panel. It was also, from Claire's perspective, exactly the kind of result that appeared when the contamination was not from the blood draw. She stared at it for 30 seconds. The number, the specific marker, the symptom cluster she had assembled. Across 5 patients, they were forming a shape she recognized. Not perfectly, not with the certainty she'd need to take it to an attending and be taken seriously, but enough to make the back of her neck tighten in the way it used to tighten in the field when a situation was about to become unmanageable. She stood up and crossed the floor to where Velt was reviewing notes at the central station. "Tox preliminary on patient 1, she said. "I think the elevated marker warrants more than a repeat draw." Velt looked up. The lab flagged it as a likely contaminant. Labs flag things as likely contaminants when they don't have a better explanation. That marker is real. It could be a single causative agent across all 5 presentations. The hemorrhage pattern in 1, the lung involvement in 2, the neuro changes in 3 and 4 minutes. "You've assessed 3 and 4? She held his gaze. "I've been monitoring all 5. Your assignment is Bay 4 DAWs. My patient in Bay 4 has a tracking deficit and a headache he's describing as pressure behind the eyes. Description, combined with the tox marker, combined with minus. You're not a physician," he said. Not harshly, just flatly. The way you state a fact that you think should end a conversation. You're also not a toxicologist. When the full panel returns, we will review it as a team. Until then, we manage confirmed findings. She stood there for a moment. Apartment noise moved around her, steady, professional, oblivious. "Document your observations formally, if you want them on record," he said, already turning back to his notes. "That's what the chart system is for." She went back to her station. She documented everything, every bay, every finding, every specific detail she had gathered since 7:26 a.m. in precise, clinical language that was careful and accurate and would mean nothing to anyone who read it without context, and everything to anyone who understood what they were looking at. Then she went back to Bay 5. The patient there, she had been thinking of him as patient 5, though she suspected he was the most senior of the group in more than age, had shifted position. He was no longer sitting up with his arms crossed. He was still upright, but his posture had changed slightly. A small accommodation, and his right hand was resting flat on the blanket. 3 of them have shown clinical changes in the last hour, he said when she entered. 2 have been officially addressed. 1 is pending imaging. And the 4th? 3, she said. Your patient in Bay 3. I'm concerned about him. His numbers are the best of ours. I know. He looked at her steadily. You've been running your own parallel assessment of all 5 of us since we came in. It wasn't a question, so she didn't answer it like one. What do you think is happening? he asked. She was trying to decide how much to say not because she didn't trust him, because stating a hypothesis that turned out to be wrong in front of someone who knew how to evaluate competence was a different kind of risk than stating it in front of Velt when the far door of the department opened. A man walked in who was not wearing a hospital badge. He was somewhere in his mid-40s, wearing dark civilian clothes, carrying nothing. He assessed the room in approximately 2 seconds. She watched him do it, ticks that started at the entry points and ended at the people in authority. And then he walked directly to Velt with the unhurried certainty of someone who knew exactly what authority he was carrying and didn't need to perform it. He showed credentials. Small black wallet, brief exposure. Velt's posture shifted in the way it shifted when he was encountering someone whose rank he wasn't sure how to measure. The man leaned in and said something quiet. Velt listened. Then Velt's eyes moved across the department in a slow, scanning way, and they stopped on Claire. Not because she'd moved, not because she'd done anything to draw attention, but she was the only person in the department who was standing still, and she was standing still because she was watching the man at the central station. And he had seen that. The man said something else to Velt. Velt's expression shifted in a way she couldn't quite interpret from across the room, something between confusion and recalibration. Then the man walked toward her. He moved with the particular economy of someone who had spent significant time in environments where unnecessary motion was a liability. Stopped at the entrance to Bay 5 and looked at her, then briefly, at the patient in the bed, then back at her. "Agent Darren Koss," he said, quietly. Enough that it didn't carry. He showed her the credentials briefly federal, with a military liaison designation. "I need 30 seconds. She stepped to the side of the bay entrance, out of the direct line from the central station. "You've been assessing all 5 patients independently," he said. It was not a question. "I've been doing my job," she said. "You flagged an abdominal case before the pressure dropped, a pneumothorax before it decompensated, and 2 separate neurological presentations that the attending hasn't formally acknowledged yet." He said it without inflection, like a man reading a list he'd been given, not standard nursing intake. She said nothing. "The tox preliminary on bed 1, he said. "What does it suggest to you?" She looked at him carefully. "What do you already know about the accident site?" Something moved briefly across his face, the slight adjustment of a man who wasn't expecting the question to come back. Enough to know that whoever recognizes that marker isn't going to have learned it from a textbook. The monitors in Bay 3 alarmed. She was already moving before the sound, fully registered already through the bay entrance, already reaching for the manual cuff, because already reaching for the manual cuff had been giving her a reading she didn't trust for the last 20 minutes, already calling over her shoulder for Okafor as she cleared the distance across the floor. Patient 3 was conscious but wrong. His color had moved past the dull grayness she'd cataloged earlier into something more active, a pallor with a sheen of perspiration that hadn't been there 8 minutes ago. His breathing had changed from the slow, deliberate pattern she'd watched him maintain into something shallower and faster. He looked at her when she entered and said, with the economy of a man who understood how to report a situation, "It got worse about 3 minutes ago." "I didn't want to." "You did the right thing," she said, which was not what she was thinking. What she was thinking was that 3 minutes was too long, and the fact that he'd waited 3 minutes to trigger the alert was probably because he'd been trained to manage the instinct to call for help, and that training was currently working against him. He had the cuff on him and a reading in her hand before Okafor reached the bay entrance. She turned and delivered the numbers clearly. Manual BP is 89/64. Monitor was showing 104/70. Respiratory rate is 22, was at 14 on his last documented vitals. Onset of diaphoresis approximately 3 minutes ago. I need someone to look at his abdomen, and I need the tox team paged. Okafor looked at the numbers she was holding up. He looked at the patient. He went to get Velt. Velt arrived in 40 seconds. He was followed by Farrar, and he was followed, at a slight distance, by Agent Koss. Velt moved to the bedside and began his assessment. He did not look at Claire. He did not acknowledge the numbers she'd delivered. He examined the patient with the focused competence of a man who was genuinely good at his job when the situation was in front of him and impossible to dismiss, and within 90 seconds, he had the same picture she had been trying to hand him for the last 30 minutes. Called for emergency imaging. He called for the tox team. He ordered a second IV line. He did all of it without once looking at Claire, who was standing 2 feet from the bed handing equipment to Farrar in the correct order without being asked. Agent Koss watched from the bay entrance. His eyes were not on the patient. They were on Claire, and when Velt finally stepped back to let Farrar manage the lines and turned to speak to Okafor, Koss moved to stand beside her and said very quietly, close enough that it didn't carry over the monitor sounds, the marker in the tox preliminary. There's a specific compound it's consistent with, classified, experimental. It causes delayed multi-system failure in a sequence that doesn't match any standard presentation profile. He paused. The reason the monitors keep showing stable is because the compound disrupts the feedback mechanisms before it disrupts the systems themselves. Claire said nothing for a moment. She was watching Farrar work. The IV line was going in correctly. The sequence, she said. Coagulation first, then pulmonary, then neural, then cardiovascular, but presenting in reverse order of severity. Koss went completely still beside her. How do you know that sequence? He said. She didn't answer. Behind them, the monitor in Bay 5 alarmed patient 5, the one with the best vitals, the one who had been sitting calmly all morning, managing his own tremor with the practiced stillness of a man who understood how to wait. His blood pressure had just dropped 11 points in under 2 minutes. Claire was already moving, and somewhere behind her, she heard Agent say something into a phone he hadn't visibly produced. Something short and clipped that she didn't catch because she was already through the bay entrance and reaching for the manual cuff and looking at the patient, at Commander Reese, though she didn't know that name yet, and his eyes were open and tracking. And he was looking at her left wrist, the watch under her sleeve, the cracked crystal, the NATO strap, the specific model that had not been commercially manufactured in 14 years, that had been issued exclusively to one unit in one theater during one classified operation that was no longer in any public record. He looked at it for 2 seconds. Then he looked at her face, and what crossed his expression was not surprise. It was something much more complicated than surprise. It was the look of a man who has been hoping someone would show up and has just realized that someone already has. Reese looked at the watch for 2 seconds, then looked at her face. And Claire had spent enough time in rooms where recognition was dangerous to know exactly what was happening. Behind his eyes, not surprise, not confusion, but the specific recalibration of a man who has been operating under one set of assumptions and has just been handed evidence that those assumptions were wrong from the beginning. She didn't acknowledge it. She had the blood pressure cuff on his arm and a reading in 10 seconds. The number confirmed what the monitor had flagged, an 11-point drop that was not a drift, not a calibration error, not something to footnote and recheck in 20 minutes. Pressure was falling in the pattern she'd been tracking mentally since 26, and the fact that it had held this long before dropping was either a testament to his conditioning or a warning that the compound had been working on a slower clock than she'd estimated. Either way, the window for getting ahead of it was narrowing. Rate your pain right now, she said. 4, he said. Chest, bilateral. Started about 6 minutes ago. You didn't call. I was watching you work. He said it without apology. Wanted to see what you'd do with 3 before I decided whether to flag 4. She would have told him that was a dangerous calculation, if she'd had time for it. Instead, she turned and called toward the bay entrance, not loudly, not with the theatrical urgency that caused rooms to freeze, but with specific controlled projection of someone who needed to be heard without creating panic. I need Velt in Bay 5. Now. Koss was already there. He stepped inside without being asked and looked at the monitor, then at Claire, then at Riss, in a way that carried a silent, compressed exchange of information she didn't have the full context for yet. His team, Koss said to her quietly. He's the unit commander. I know. Then you know he's the primary target for the debrief. We need him conscious and stable. Then stop talking and let me work. Koss stepped back. He was not a man accustomed to being told to step back, and he did it anyway, which told her something useful about how seriously he was taking the situation. Welt arrived in 90 seconds, which was faster than she'd expected. He came through the entrance, assessed the monitor, looked at the manual reading Claire had written on the bay whiteboard, because she'd known that would be faster than waiting for him to pull the chart, and something shifted in his face, not quite alarm, but the specific tightening of a physician who has been operating under a clinical picture that has just been revised without his permission. What changed? He said. Bilateral chest pain onset approximately 6 minutes ago. BP dropped 11 points in under 2 minutes. It follows the same pattern as patient 1 but is later, which is consistent with the commander having a higher baseline physiological tolerance. I need you to look at his abdomen. Welt was already palpating before she finished the sentence. Reese didn't react to the pressure, which was the same wrong absence of response she'd clocked in patient 1 2 hours ago. Welt felt it. She could see him register it, the way his hands paused fractionally at the left flank. Get imaging on the line, he said to Okafor, who had appeared in the doorway. And get me the tox team. Where is the tox team? Why aren't they already? They're with patient 3, Okafor said. Then I need one of them in here. They're in the middle of a procedure. I don't care. Welt's voice went flat in the way it went flat when he was actually worried rather than administratively irritated. Get me one of them. And pull off tox preliminaries on the same screen. I want to see them together. Claire was already at the monitor, adjusting the alarm threshold to account for Reese's current trajectory. She caught Reese watching her from the bed, still tracking, still oriented, managing the pain with the same practiced suppression he'd been applying to the tremor all morning. You're going to feel worse before the intervention starts working, she said to him, quietly enough that it was between them. Don't try to manage it down. Let me know when it changes. Understood, he said. Then after a beat, nightfall. She stilled for a fraction of a second. Just a fraction. Then she finished adjusting the monitor threshold and straightened without looking at him. Focus on your breathing, she said. She left the bay before he could say anything else. The department had changed while she'd been in with Reese. The easy, managed rhythm of the early morning labs pending, imaging cued, everyone officially stable, had given way to something faster and less comfortable. The tox team, 2 specialists who had arrived from the lab division 20 minutes earlier, were now split between bays 3 and 5. Okafor was on the phone with radiology. Farrar was managing the secondary IV on patient 3. 2 interns were moving supplies and staying out of the way, which was the most useful thing they could do. At the central station, Welt had pulled the 5 tox preliminaries onto a shared looking at them with the expression of a man who has been handed a puzzle and is only now realizing he doesn't have all the pieces. The elevated marker from patient 1's blood work was present in varying concentrations across 3 of the 5 panels. The other 2 panels, patients 3 and 5, didn't show it. But that, Claire knew, was not the reassurance it appeared to be. It meant either the compound was metabolizing differently in those patients, or the standard preliminary panel wasn't testing for the right markers to catch it. She walked to the station. The marker concentrations are different because the exposure wasn't uniform, she said. Depends on proximity at the time of the accident and individual metabolic rate. The patients who don't show it on the preliminary might be processing it through a different pathway. Full tox panel needs to include. She stopped because she was about to name a specific metabolite, and she didn't have a clean explanation for how she knew to name it. She redirected. The full panel needs to be expanded. Standard screening won't catch all the breakdown products. Welt turned from the screen. He looked at her in a way that was different from the way he'd been looking at her all morning. Not warmer, Velt wasn't warm, particularly, but more focused. The way you look at something you'd been ignoring that has started making sounds you can't account for. What do you think we're dealing with? He said. It was the first time he'd asked her a direct clinical question. She chose her words carefully. A compound that disrupts feedback mechanisms before it disrupts systems. The monitors look stable because the body is compensating, but the compensation has a ceiling. When each patient hits that ceiling, they deteriorate fast. The sequence is coagulation first, then pulmonary, then neural, then cardiovascular. But the cardiovascular presentation is delayed and severe, which means by the time the heart shows up on the monitor, other systems are already significantly compromised. Velt was quiet for a moment. But that's a very specific sequence, he said. Yes. Where did you read that? She held his gaze. I'd like to formally recommend expanding the tox panel. Can write the specific markers if you authorize the request. He stared at her for 3 full seconds, long enough that it became noticeable, long enough that Okafor, who had ended his call and was hovering nearby, glanced between them with the uncertain expression of someone who can feel a room changing temperature without knowing why. Write the markers, Velt said. She went to a workstation and started typing. She was 3 markers in when she felt someone come to stand at her shoulder. Expected costs. It was Farrar. You called the pneumothorax before the monitor did, Farrar said. She wasn't being accusatory. She was being precise, which was different. And the abdominal bleed. And now you're giving Velt a compound sequence from memory without citing a source. Claire kept typing. The patients needed interventions. I'm not criticizing you. I'm asking who you are. I'm a trauma nurse. Bay 4. Farrar was quiet for a moment. Right. She didn't move away immediately. The marker you just listed, the third one. That's not in any civilian toxicology textbook I've read. And I've read most of them. Claire finished the list and stood up. She handed the printed sheet to Farrar. Give that to Velt. Farrar took it. She was still watching Claire, with the careful, assessing expression of someone who was building a theory and wasn't ready to say it out loud yet. At 9:44 a.m., patient 1 came out of emergency surgery. The abdominal hemorrhage had been more extensive than the initial imaging suggested, a slow bleed from a lacerated vessel that had been masked by the patient's pain tolerance and the compound's effect on the body's inflammatory response. The surgical team had managed it, but the attending surgeon, Dr. Lena Price, came back to the trauma floor with the particular tightness around the eyes of someone who had worked harder than they'd expected to. This wasn't standard trauma, Price said to Velt, standing at the central station and keeping her voice low. The tissue around the laceration was behaving abnormally. Poor clotting response, unusual vascular reactivity. Whatever these men were exposed to, it's affecting tissue at a level we're not going to catch on standard imaging. We have a tox team on it, Velt said. The tox team doesn't know what they're looking for. Price's voice was level but firm. I've been in that OR for the last hour, and I'm telling you the presentation is unlike anything in my experience. We need someone who's seen this before. The department was quiet enough in that moment that Claire, standing at the supply station 12 feet away, heard every word, carried the medication cart she was loading to Bay 4, and set it down and stood with her hands on the edge of the cart for a moment, looking at the wall. She had been at Harlow for 11 weeks. She had spent 11 weeks being precise and quiet and careful, doing her job correctly, not asking for anything, not drawing attention. She had built this version of herself, the late bloomer, the ordinary nurse, the woman with the unremarkable credentials, with a specific purpose, and that purpose was to exist in a civilian environment without carrying the weight of what she'd done before into every room she entered. But there were 5 men in this department who were dying in a sequence she knew, from a compound she recognized, and the physicians responsible for them were working with incomplete information that she had, and the space between her maintaining her cover and those men surviving was getting smaller by the minute. She left the cart. She walked back to the central station. Velt and Price were still there. Koss was now standing nearby, not pretending to be anything other than what is was. She stood in front of all three of them and said, at a volume that was audible but controlled, I need to say something, and I need you to hear it without stopping me. Velt's expression tightened. Price looked at her with the attention of someone who had just had the OR confirm her worst clinical instincts. Koss went very still. The compound these men were exposed to targets multiple systems in a specific sequence, Claire said. The reason your standard interventions are partially working is because you're treating each presentation as a separate injury. But they're not separate. They're stages. Every one of these patients is going to hit a cardiovascular event in a window that I estimate is between 3 and 6 hours from initial exposure. Patient 1 has already hit his coagulation, and vascular stage surgery bought him time, but the compound is still active in his system. Patient 2's pulmonary stage is managed but not resolved. 3 and 4 are in the neural stage right now. 5, she paused. 5 is ahead of the others. His cardiovascular window may be shorter. Price was looking at her with an expression that had moved past assessment into something rawer. How do you know there's a cardiovascular stage? Because the compound has a documented progression. Documented where? In a context I'm not at liberty to discuss at this station. That's not an answer? No, Claire said. It's not. She looked at Velt. I can tell you what to watch for in the cardiovascular presentation and how to preempt it. I can tell you which interventions will work and which will make it worse. I can give you a management protocol for all 5 patients that accounts for where each of them is in the progression. But I need you to authorize me to work directly on the clinical team, not as the Bay 4 nurse, as part of the primary management. The department was not silent. Monitors beeped. Someone's phone rang 2 stations over. A cart wheeled past behind her. But in the immediate space around the central station, no one spoke for a moment. Okafor had drifted close enough to hear. 2 of the tox team specialists had looked up from their workstation. Farrar was standing near the Bay 2 entrance, with the tox marker list in her hand, watching. Velt said, "You're a first-year trauma nurse. I'm aware of how I'm listed in this system. Can't put a first-year nurse in primary clinical management of 5 military patients in a complex tox case. You can authorize expanded scope in an emergency. That provision exists in Harlow's protocol, and you know it." His jaw moved slightly. He did know it. It was used approximately never, for situations that were approximately never this specific. On what basis? He said, "Do I authorize that?" Koss spoke for the first time since the conversation started. He spoke at normal volume, without preamble, in the tone of someone who is used to sentences landing with weight. On the basis that she's given you 3 accurate preclinical flags today, a correct pathophysiological sequence for an agent your tox team doesn't have in their database, and a management framework that is more specific than anything your department has generated this morning. He paused. That's the basis. Velt looked at Koss. He looked at Price. Price gave him a small, tight nod, the nod of a surgeon who has been inside a patient and knows what she's dealing with better than the person running the department does. Velt looked at Claire. "You're on primary team," he said. "But this conversation is not finished." "It doesn't need to be finished yet," she said. "It needs to wait until they're stable." She was already moving toward Bay 5 when she heard him say, "Skeleton particular," to no one in particular, and everyone in earshot. Someone pull her full personnel file. "I want everything." She kept moving. Reese was worse. Not dramatically, he hadn't crashed, hadn't lost consciousness, hadn't hit the kind of acute presentation that would have had the bay full of people and equipment. But the bilateral chest pain had increased. His pressure had dropped another 6 points despite the IV fluid running, and there was now a slight irregularity in his cardiac rhythm. On the monitor that was subtle enough that the overnight resident doing a casual check might have attributed it to movement artifact. Claire looked at it and felt her stomach tighten. "How's the chest?" she said. "Worse," he said. He was not a man who exaggerated symptoms, which meant he was telling her that the pain had moved past manageable into something he was actively working to function through. Tighter, both sides, like compression. "Okay." She adjusted his monitoring leads, checked the IV rate, made a notation on his chart. Her hands were steady. They were always steady when she was working. It was one of the things that used to settle people who knew what she'd done before. The way her hands didn't shake, even when her mind was running the full catastrophic calculation of what could go wrong. "You're not going to tell me what's happening," he said. "I'm going to tell you that we have a management plan, and you're part of it." That's a very nurse answer. Yes. He was quiet for a moment. His right hand moved slightly on the blanket, and she watched the tremor surface for 2 seconds and disappear. "The watch," he said. "Don't. I'm not going to say anything that shouldn't be said here." "Then don't say anything at all." He accepted that. It was one of the things she'd always found both useful and unsettling about men like Reese. They understood the architecture of silence, when it was a wall and when it was a door. She finished her chart notations and stepped into the hallway outside Bay 5, where Koss was waiting, with the particular patience of a man who had been in enough operational situations to know that the moment he pushed was the moment he'd lose the cooperation he needed. "His cardiac rhythm is showing early irregularity," she said quietly. "He needs continuous monitoring, and I want cardiology on standby." Cardiovascular stage in this compound progression can move from early irregularity to acute event in under 40 minutes. In a high-tolerance patient, the conditioning actually works against them. Compensate right up until they can't. "I'll get cardiology," Koss said. "Then I need to ask you something, and I need an honest answer." "You can ask." "The compound, the sequence you described, the metabolites on that list you gave Velt." He looked at her directly. "How recent is your knowledge?" She understood what he was really asking. Not whether she'd read a paper or attended a seminar. Whether the information was operational. Current. From a source that would have access to classified experimental agent that, as of 3 hours ago, officially did not exist. "Recent enough to be relevant," she said. "That's not specific." "No," she said. "It's not." She paused. "Is the compound still being developed? Or was this a deployment test?" Something crossed his face, brief, controlled, but there. "That's not information I can share with a civilian nurse." "Then we're both keeping things from each other," she said. "And 5 men are deteriorating while we do it." He held her gaze for a long moment. Whatever calculation he was running, he ran it to completion, and then put it aside. "What do you need to keep them alive through the cardiovascular window?" she told him. It took 4 minutes, and she was specific enough that twice during the conversation, his expression shifted in the way it shifted when someone says something that confirms rather than introduces a suspicion. He didn't interrupt her. He took out his phone and typed while she talked, which she approved of, because it meant he was treating her information as actionable rather than provisional. When she finished, he said, "I'm going to need you to talk to someone. When the patients are stable, there may not be a clean window." "When the patients are stable," she said again. He nodded once. Tight, efficient, the nod of a man accepting terms he doesn't love, but can work with. She went back inside. The next 90 minutes were the kind of sustained, grinding clinical work that didn't look dramatic from the outside. No shouted orders. No running, no electric paddles against a chest, but required the particular combination of precision and anticipation that separated people who could manage a complex situation from people who could only react to one. Claire moved between bays, delivered medication adjustments, caught a secondary arrhythmia in patient 4 before it developed into anything requiring emergency intervention, and twice redirected treatment decisions that were clinically reasonable but wrong for this specific compound's behavior in the body. Each time, she gave her reasoning clearly and without hedging, and each time there was a moment shorter each time, where the physician she was speaking to considered whether to dismiss her and decided not to. Okafor stopped arguing with her assessments somewhere around the 90-minute mark. He started asking her questions instead. Farrar never argued. She watched and absorbed, and when she had a question, she asked it in a way that suggested she was checking her own reasoning, rather than challenging Claire's the behavior of a clinician who was genuinely trying to understand rather than defend a position. Velt moved through the department in a different way than he had that morning. He was still the chief. He was still the person everyone looked to for final calls. But something in his operating rhythm had shifted in a way that was subtle and real. He was checking Clearedsoft documentation before making decisions rather than after, which was the kind of behavioral change that doesn't happen quickly in a physician with 12 years of unchallenged authority. At 11:22 a.m., the full tox panel came back. Claire was at the central station when it loaded on the shared screen. She read it in approximately 45 seconds. Then she pulled up the individual patient charts and cross-referenced 3 values that she needed to see together rather than separately. The panel confirmed the compound. It confirmed the staging. And it showed something she hadn't been able to determine from bedside assessment alone, a specific metabolic marker in patient 3's results that indicated he was in a different stage than she'd estimated. Not behind the others. Ahead of them. The quiet one, the one with the best official numbers, the one who had barely spoken since arrival, was closer to the cardiovascular window than Reese. She stood up from the workstation and was already moving when Velt appeared beside her. "Panel is back," he said. "I saw it. The compound marker, confirmed across all 5. She was walking toward Bay 3. Patient 3 is ahead of my original timeline. He needs continuous cardiac monitoring, and I need cardiology in his bay in the next 10 minutes. How far ahead? Maybe 2 hours, maybe less. His metabolic rate is processing the compound faster. He's lean, high cardiovascular fitness. His system isn't buffering the way the others are." Velt walked beside her. He was not giving orders. He was keeping pace. "The panel doesn't match anything in our toxicology database," he said. "No. The lab director has already flagged it as a potential Schedule 1 compound. She's legally required to notify. I know what she's required to do." Claire. It was the first time he had used her name, not Dawes. Her name. The shift was small, and it landed with more weight than he probably intended. "The federal agent in my department. The compound that doesn't exist in any civilian database. The sequence you described from memory." He paused. "I've been doing this for 12 years. I know when a clinical picture has a story behind it." Stopped outside Bay 3 and turned to look at him. "The story," she said, "is that there are 5 men in this department who need cardiology coverage and a modified treatment protocol, and a physician who will follow that protocol exactly as I've laid it out. The only story that matters right now." He looked at her for a moment. Face was doing something complicated. She'd seen it before on people who were in the process of revising a long-held position and finding the revision uncomfortable. "You're right," he said, and it came out, roughly, like a word his mouth bracket, at forming in this direction. "We'll finish the other conversation later." "Yes," she said. "We will." She pushed open the Bay 3 door. The quiet patient, his intake sheet said, his name was Specialist Dion Ferris, was lying back against the bed with his eyes at the ceiling. His color was wrong. His breathing was wrong. His monitor showed sinus rhythm with a new small abnormality that had not been present in his last reading 20 minutes ago. He turned his head when Claire came in. "It started," he said. "Flat, reporting." "I know," she said. "We're going to manage it." She was at the monitor, making adjustments, when her peripheral vision caught movement at the bay entrance. Koss. Behind him, 2 additional figures she hadn't seen before, both in civilian clothes, both with the posture that had nothing to do with what they were wearing. And behind them, Dr. Velt, who was holding a printout from the personnel system. He was looking at the printout with an expression she couldn't read from across the bay. Koss caught her eye. He gave a small, tight shake of his head. "Not now. Not yet. The time hasn't arrived." She turned back to Ferris and did her job. But the printout in Velt's hand was thin. The file for a 34-year-old woman with 11 weeks at Harlow Memorial should have had more pages than that. It should have had a professional history, references, school transcripts, prior employer verification. All the paper architecture of an ordinary life, documented in the ordinary way. What Velt was holding was barely 4 pages. And the expression on his face when he looked up from it and found Claire across the bay was not the expression of a man who had just confirmed what he already thought. It was the expression of a man who had just discovered that almost everything he thought he knew was wrong. Welt lowered the printout slowly, the way a man lowers something, when he's not sure yet what to do with it. And Claire felt the weight of his attention across the bay without turning to meet it. She was watching Ferris, watching the monitor, watching his color, watching the specific quality of his breathing that told her more than the numbers did, and she kept watching. Because Ferris was the priority and Welt's revised understanding of who she was going to wait until Ferris wasn't about to cross a threshold that would require 3 people and a crash cart to pull him back from. The arrhythmia on his monitor was a premature ventricular complex. 1, then another 11 seconds later, then a pause. Not ventricular fibrillation. Not yet. But PVCs, in the context of this compound's cardiovascular stage, were not benign. They were the electrical system's way of announcing that something was wrong with the chemical environment the heart muscle was swimming in, and if the environment didn't change, the announcement would escalate. Claire adjusted his IV rate and reached for the medication she'd pre-drawn 20 minutes ago, a calculated decision she'd made when she'd read the tox panel and understood that patient 3 was ahead of schedule, that she'd need to move fast and couldn't afford to wait for a pharmacy pull. The syringe was in her pocket. She administered it through the IV port, checked the rate, and then stood at the bedside and watched the monitor with the focused stillness of someone who has done this before in rooms with worse equipment and worse odds. Ferris was watching her. "Is it working?" he said. "Give it 3 minutes." "What if it doesn't?" 3 minutes, she said. Not unkind. Just certain. He was quiet. The monitor beeped. Another PVC, then a long stretch of clean sinus rhythm, then another. She counted. She watched his respiratory rate. She watched his color. She was aware of the people behind her costs. The 2 additional figures, Welt with his thin printout, the way you're aware of a room's furniture in the dark, by shape, by position, by whether any of it is moving. 2-minute 40 mark, the PVCs stopped. The rhythm held. Clean, regular, the cardiac electrical system settling back into its lane, without the kind of intervention that would have had the bay full of people and noise and the controlled chaos of a code. Just a medication doing what it was calculated to do, administered at the right moment by someone who had spent the last 20 minutes ensuring the moment would arrive before the crisis did. Ferris exhaled slowly. "Better," he said. "I know." She made a notation on his chart, updated the monitoring parameters, and then turned around. Welt was still holding the printout. The 2 figures behind Koss had the particular stillness of people who were here to observe and had just watched something that revised their observational data. Koss himself had an expression she couldn't fully decode, something between relief and the focused concern of a man whose situation had just gotten more complicated. She walked toward them. She stopped in front of Welt because Welt was the one holding the paper, and Welt was the one whose authority in this room was relevant. 4 pages, he said. Yes, a 34-year-old woman with a trauma nursing certification and a 2-year employment history. He held her gaze. There's nothing before 2022. No prior employment, no school records before the BSN, no address history, before a lease in this city 2 years and 3 months ago. I'm aware of what my file contains. It's not a real file. The credentials are real. The certification is real. The license is current and valid. That's not what I mean, and you know it. He kept his voice low, controlled, professional, not angry. She'd expected anger. The absence of it was more difficult to navigate. Who are you? She looked at him for a moment. Then she looked at Koss. Koss gave a very small nod, the nod of a man who has run the calculation and decided that the controlled disclosure is better than the uncontrolled one. My name is Claire Dawes, she said. It's real. Everything else, she paused, choosing the word carefully, is simplified. Simplified, Welt repeated. I left a previous career under circumstances that required a clean start. Process was legal. The documentation was handled through channels I'm not going to describe in this bay. She kept her voice the same temperature it always was. What I can tell you is that my clinical knowledge is real. My assessments today have been accurate, and the 5 men in this department are currently alive because of interventions that I either performed or directed. That is the relevant fact. The monitor in Bay 3 beeped steadily behind her. Clean rhythm. Holding. One of the figures behind Koss, the taller one, a woman in her late 40s with close-cropped hair and the posture of someone who had spent years making rooms smaller just by walking into them, stepped forward. She had a badge holder at her belt that she didn't open. She didn't need to. Colonel Mara Stett, she said. Defense Medical Research Liaison. She looked at Claire with the evaluating attention of someone who has seen a great many capable people and is in the process of placing this one accurately. Agent Koss told me what you laid out in the hallway. The sequence, the metabolites, the staging protocol. She paused. Compound in question is not publicly documented. Pharmacokinetics are not in any open database. The staging sequence you described was established through classified trials that involved fewer than 60 people with direct knowledge. The department continued its noise outside the bay. Someone's phone. A monitor alarm 2 rooms over, quickly silenced. The ordinary sounds of a hospital doing its work. How many of those 60, Stett said, did you know personally? Claire was quiet for a moment. Enough, she said. Stett held her gaze. We're going to need the full conversation. After my patients are stable. Miss Dawes? Colonel. Claire's voice didn't change in temperature, but something in it shifted the faint, structural quality of someone who has given orders in circumstances where giving them incorrectly cost lives and who has not entirely lost the reflex. I have a patient in Bay 5 who is approximately 90 minutes from the same window that patient 3 just came through, and he is going to need the same intervention at the right moment, or he will go into acute cardiac event. I have 2 other patients whose staging I need to reassess with the updated tox panel data. I have a 4th patient who has a neurological development that your team has not yet addressed. She paused. You can have the full conversation in 3 hours, so you can have a shorter version in pieces between now and then. What you cannot have is my undivided attention while men are dying down the hall. Stett looked at Koss. Something moved between them, not words, just the compressed communication of people who have worked together long enough to transmit position changes without speaking. 3 hours, Stett said. We'll be here. Claire turned back to Bay 3. She adjusted Ferris's monitoring leads, confirmed his vital trend on the chart, and told him to flag any new chest sensation immediately and without waiting to see if it resolved on its own. He nodded with the compliance of a man who had been given a direct instruction by someone whose competence he has just watched demonstrated on his own body. She left the bay and moved to the hallway, where she needed 30 seconds to stand still and think, without anyone watching her do it. She got approximately 12 seconds before Okafor appeared. Patient 4 is asking for you specifically, he said. Clinical? He says his headache is different. Not worse different. He's trying to describe it as pressure that moved. She was already walking. Patient 4 Corporal, Aldous Reeve, she'd caught his name from the chart update, was the youngest of the 5, and the one who'd been least willing to articulate his symptoms, which was not unusual for his demographic and his profession, and was also actively working against his treatment. He was 26, with the lean, coiled build of someone in peak physical conditioning, and he had spent the morning answering medical questions with the minimum number of words that constituted a technically complete response. But he'd asked for her. That meant something had changed enough to override whatever internal protocol he had about not raising the alarm. She went in. His posture had shifted. He was sitting partly up, which was different from the supine position he'd maintained all morning, and the change was reflexive rather than deliberate, the kind of postural adjustment the body makes when it's trying to redistribute discomfort. Face was controlled but tighter than it had been. Tell me about the pressure moving, she said. It was behind both eyes. Now it's, he paused, reaching for the right language. Higher. behind my forehead. And there's something on the right side that isn't pain exactly, more like another pause. Visual noise, like interference, like static, in my peripheral. Right side. Started about 20 minutes ago. She was already reaching for the pen light. His left pupil was sluggish. She'd documented the early sign of that hours ago. But the right pupil now showed a different quality, a slight asymmetry in the reactivity that had not been present in her last assessment. Combined with the described visual static in the right peripheral field, combined with the headache migrating from retroorbital to frontal minence. "You should have told me 20 minutes ago," she said. "I know. Why didn't you?" He looked at her, because the others seemed worse. She held the pen light steady and looked at his eyes for a moment past the clinical requirement. 26. He had been trained to absorb pain and minimize it and continue functioning. That training was an asset in the field and a liability in a hospital bed, and nobody had told him how to calibrate the difference yet, and he was now sitting in front of her with a neurological change that had been progressing for 20 minutes, while he quietly decided that other people's emergencies took priority over his own. "Your emergencies count," she said. "Whatever they told you before here, your emergencies count." He blinked. It was a small thing, but it was real. She documented the findings, ordered a repeat CT head through Velt's authorization, and spent 3 minutes explaining to Okafor, who arrived while she was finishing the notation, exactly why the imaging needed to be read by someone who understood the compound's neurological mechanism, rather than a standard radiology protocol. Okafor listened this time. He didn't argue. He picked up his phone and called radiology directly. CT was queued within 8 minutes. She moved to Bay 2, where the pneumothorax patient Petty Officer Gareth Loon had been stable since the chest drain, but whose most recent vitals showed a respiratory rate creeping up again in a way that was familiar and unwelcome. The drain was patent. The lung was re-expanding on imaging, but his oxygen saturation was 95% when it should have been trending upward toward 97%. And the flat line of it told her the re-expansion was slower than expected. The tox panel on lung showed the compound at a slightly different concentration than the others higher, in fact, which was consistent with proximity to the source at the time of exposure. The higher concentration meant the pulmonary inflammation was more aggressive. The chest drain was managing the mechanical problem. It was not managing the chemical environment the lung tissue was sitting in. She found Price, the surgical attending, in the hallway outside Bay 1, reviewing the post-op notes on patient 1. "Lung saturation is plateauing," she said. "The re-expansion is happening, but his tissue inflammation is working against it. Compound concentration in his panel is the highest of the 5. I think we need to consider a short-course anti-inflammatory protocol alongside the drain management specific agent, specific duration. I can give you the parameters." Price looked at her. They had not had a direct conversation until this moment, but Price had been in the OR for 90 minutes with patient 1's abnormal tissue and had come back to the floor with a revised understanding of what they were dealing with. "What agent?" Price said. Claire told her. Price typed it into her phone, looked it up, looked at Claire. "This isn't standard for pneumothorax management." "No. It's specific to the compound's mechanism in pulmonary tissue. The inflammatory cascade it triggers is different from standard trauma-induced inflammation. Standard management will keep him from getting worse. This will actually start addressing the cause." Price was quiet for a moment. She was a careful person, careful in the way of someone who had learned that medicine punished shortcuts and rewarded verification. "How confident are you?" "Confident enough to recommend it. Not confident enough to be certain. Nothing about this compound allows certainty. That's honest. It's all I have." Price ordered the protocol. 12:47 p.m., when the oxygen system alarmed. Not a patient monitor the building system. The alarm came through the overhead panel in the main trauma corridor, a sustained double tone that the department's senior staff knew and the junior staff learned immediately. By the way, the senior staff responded to it. Harlow's trauma department operated on a dedicated oxygen feed, separate from the main hospital line, because the people who had designed the department 30 years ago had understood that the one thing you could not have interrupted in an emergency trauma setting was the gas supply to the ventilators and the anesthesia, equipment, and the supplemental oxygen running to every bed. The alarm meant the dedicated feed was failing. Okafor looked up from his station. Farrar came out of Bay 2. The two interns froze in the middle of the corridor like people who had just heard a sound they'd read about in school and hoped never to hear in practice. Claire heard it and felt something in her chest go cold and specific. All 5 SEALs were on supplemental oxygen. 3 of them had it as a critical component of their current management. Loon, whose lung re-expansion was dependent on the maintained pressure. Ferris, whose cardiac medication worked better with adequate oxygenation. Reese, whose cardiovascular window was already narrow and whose margin for any additional physiological stress was essentially 0. She moved to the gas panel in the corridor, a wall-mounted monitoring board she'd identified in her first week as something she needed to understand. The display showed pressure dropping in the dedicated feed line, not crash dropping. The supply was still there, but diminishing. "What's the backup protocol?" she said to the charge nurse, Nina Wald, who had appeared from the administrative section at the sound of the alarm. "Backup tanks. In the supply room at the end of the corridor. They're manual. Someone has to physically connect them to the bed ports. How many tanks? Should be 12. Enough for all the bays plus reserve. Should be?" Wald's expression flickered. The last inventory was 3 weeks ago. Claire looked at the pressure display. Still dropping. "Get someone to that supply room right now and count what's there. I need to know the actual number before we have to start making allocation decisions." Wald went. Claire turned to Okafor. "Pull oxygen saturation readings on all 5 military patients right now. Not the monitor trend current. Manual, in person. I need to know where each of them is starting from before the feed pressure drops any further." Okafor moved without a word. She went to Bay 5. Reese was awake and had heard the alarm. Of course, these were men who woke from deep sleep at the sound of a safety mechanism activating, whose entire professional history had trained them to identify the auditory signature of a system failing. He was sitting up, monitoring his own body, with the focused internal attention of someone's assessing their own operational status. And he looked at her when she came in with the expression of a man who wants accurate information rather than management. "Oxygen system?" he said. "Feed pressure is dropping. We're switching to backup tanks. Is there enough?" "Counting right now." "Straight answer," he said. "Is there enough?" She held his gaze. "I don't know yet." He accepted that. His saturation on the monitor was 96%, which was adequate but not the buffer she wanted given what his cardiovascular system was about to face. She checked his supplemental flow rate and made a calculation if the tanks were below capacity or fewer in number than the inventory suggested. She was going to have to make decisions about allocation, and those decisions were going to be medical and brutal, and she needed to know the numbers before she had to make them act. Her radio, the department communication device, clipped to her scrub pocket, crackled. Wald's voice. 8 tanks, not 12, and 2 of the 8 are at less than half capacity. Tanks, 2 partial. Enough for perhaps 4 full-need patients for the expected duration of the feed failure, which was still unknown. She had 5 patients on supplemental oxygen, plus 2 additional trauma bays currently occupied, and 2 ventilated patients in the adjoining critical care section who shared the feed line. Stood in Bay 5 for exactly 4 seconds and ran the triage calculation. Then she went to find Velt. She found him in the corridor outside Bay 3, having the same alarm conversation with Stet that she needed to have with him, which meant she interrupted it without apology. "Oxygen system," she said. 8 backup tanks, 2 partial. I need authorization for manual allocation protocol. I have a priority order for the military patients based on their staging. Give it to me, Velt said. She gave it to him in order Reese first, because his cardiovascular window meant any desaturation would precipitate the event she'd been managing to prevent. Ferris second, because the cardiac medication's efficacy was oxygen-dependent. Lund third, because his pulmonary re-expansion needed the pressure support. Reeve in patient 1, who was post-surgical and most stable of the group, lower priority for the supplemental feed, with monitoring to catch any change. Velt listened. He didn't interrupt. When she finished, he said, authorized. You manage the allocation. Nina has the tanks. She turned and went. She was at the supply room with Wald, assessing the actual pressure readings on the individual tanks, when she heard Okafor's voice on the radio. Urgent, controlled, the voice of a resident who has arrived at a bedside and found something that the monitor had not yet reflected. Bay 3. I need someone in Bay 3. She handed the tank assessment to Wald with a spoken instruction about the connection sequence and ran. Ferris was in ventricular tachycardia, not fibrillation VTAC, which was faster and more organized than fibrillation, and slightly less immediately fatal, which was the most optimistic thing that could be said about it. The monitor was alarming with the sustained, high-pitched tone of a rhythm that was incompatible with adequate cardiac output, and Ferris was conscious awake, aware, his face the pale gray of a man whose heart is beating at 180 beats per minute and delivering approximately half the blood flow his body needs. I feel it, he said when she reached the bedside. His voice was thin. I know what this is. You're going to be okay, she said, and she was reaching for the crash cart before she finished the sentence. Not because it was certainly true, but because in this situation the most useful thing she could do was act as if it were. Okafor was behind her. I've called cardiology. How long? 4 minutes. 4 minutes was 4 minutes. She pulled the defibrillator leads, checked the rhythm on the cart's own monitor to confirm VTAC, sustained, rate of 182, and made the decision before cardiology was in the room, because the decision needed to be made now, with the resources available now, not in 4 minutes, when the situation might be different in the wrong direction. She administered the antiarrhythmic through his IV. The same agent she'd used in the preliminary management, at a higher dose, calculated for the rhythm she was looking at, and the compound's specific effect on the cardiac conduction system. She told Okafor what she was doing and why, as she did it, not for permission, but because Okafor needed to understand the reasoning, and because a decision made visible was a decision that could be evaluated. She watched the monitor. 15 seconds. 20. The rhythm stayed at 182. Ferris's color was deteriorating. At 28 seconds, the rate dropped. 174. Then 165. Then, in the next 30 seconds, a stuttering descent. 155. 148. 139. 45 seconds from administration, the rhythm broke. The monitor showed a return to sinus, with a rate of 97, slightly fast but organized, the electrical system finding its, again, with the visible, line graph relief of a crisis ending. Ferris closed his eyes for 3 seconds. Then he opened them. That was bad, he said. Yes, she said. There was no point in telling him otherwise. The cardiology team arrived in the doorway 30 seconds after the rhythm converted. The senior cardiologist, Dr. Paige Ulmer, 51 years old, with the particular weariness of someone who has been called to emergencies long enough that she assesses the room before she assesses the patient, looked at the monitor, looked at Ferris, looked at Claire. Converted? She said. 48 seconds ago. Antiarrhythmic, IV. The agent and dosage are in the chart. Ulmer looked at the chart on the wall tablet. She looked at the medication selection. She looked at Claire again with an expression that was not quite surprise and not quite recognition, something in between. Who ordered this? I administered it under emergency protocol with Dr. Velt's authorization for expanded scope. This agent, at this dose, is not standard antiarrhythmic management. No. It's specific to the compound these patients were exposed to. It works on the conduction pathway the compound disrupts. Standard antiarrhythmics wouldn't have been fast enough. Ulmer was quiet. She looked at the monitor sinus rhythm, rate 94 now, holding. She looked at Ferris, who was conscious and oriented and breathing with more ease than he had 60 seconds ago. "You know this compound," Ulmer said. It was not a question. "I know enough," Claire said. "And right now I need your team maintaining cardiac monitoring on Bay 3 and Bay 5 continuously. Bay 5 in particular, Commander Reese, is going to hit the same window in the next hour and a half, and I need you there when he does." Ulmer looked at her for a moment with the evaluating attention of someone revising an assumption in real time. "I'll be in Bay 5 in 10 minutes, she said. "Thank you." Claire left the bay. The oxygen system alarm was still sounding in the corridor, a sustained presence behind everything else. She checked the status on the wall panel, pressure still dropping, backup tanks connected in 3 of the 5 military bays now. Walled working through the sequence. The situation was manageable. Barely, and for a limited window, but manageable. She was updating the allocation status on the central system when she felt the specific quality of being watched, not the general awareness of a busy department, but the particular directed attention of a single person who has decided to stop waiting. Turned around. Reese was standing in the corridor, not in his bay, not in his bed. Standing in the hallway in his hospital gown with the supplemental oxygen line disconnected from the wall port and the portable unit in his hand, he'd found the portable tank in the bay's emergency supply cabinet, which meant he'd been looking for it, which meant he'd been watching the situation, developed up, and had made a decision about his own management that had not involved asking anyone's permission. He was pale. His hands were not entirely steady. He was holding the portable unit with a grip that was tighter than necessary, which was the only visible sign of how much effort the standing was costing him. "You should be in bed," she said. "I heard the VTAC alarm from Bay 3, he said. "Dion?" "Converted. He's stable." Something in his face settled. It was the only word for it, not relief exactly, but a weight redistributing. "You need to go back to your bay," she said. "I need to talk to you." He said it with the quiet authority of a man who has been managing his own urgency for the past several hours and has reached the limit of what management achieves. Not as a patient. 2 minutes. She looked at him. Portable unit in his hand, the oxygen line, the pallor. He had perhaps 90 minutes before his cardiovascular window opened, and he had spent some portion of that getting out of bed to find her. 2 minutes, she said. He looked at her left wrist. She had not pushed the sleeve down. She couldn't remember, in the last hour's work, when it had ridden up, but the watch was visible, the cracked crystal, the NATO strap, the specific model that no longer existed in any commercial catalog. "Nightfall unit," he said, quietly, not loudly enough to carry. "I was the mission commander for the extraction in Sector 12. March 6 years ago." She kept her face still. "The medic who came in last," he said. "The one who wasn't supposed to be there. The one who held the perimeter for 11 minutes alone while the team got the wounded out." He paused. She was listed as KIA in the after-action report. The department moved around them. The alarm continued. Somewhere down the corridor, a monitor beeped. "Records can be wrong," she said. He looked at her for a long moment. His right hand had the tremor again, the fine, persistent movement that he was no longer bothering to suppress. "Compound," he said. "The one that's killing my team. You know it because you were at the development site." She said nothing. "You were there when they tested it." Still nothing. "Were you a test subject?" he said. "Or were you there for another reason?" Behind her, she heard a door open, the Bay 3 door, the cardiology team going in or coming out. She couldn't tell without turning. And behind that, footsteps she recognized by their pace and weight. Stet, approaching from the direction of the administrative section with the unhurried certainty of a woman who has waited long enough and is done waiting. And from the other direction, Velt, with his thin printout still in his hand, and a new edition, a second sheet, something he'd clearly just printed, something that had arrived through whatever official channel he'd used to request it. He was reading it as he walked. He looked up, and he found Claire, and his expression was the most unguarded it had been all day. He stopped walking. He looked at the second sheet again. He looked at her. He looked at Reese, standing in the corridor in a hospital gown with a portable oxygen unit, and he looked back at the paper. This came through the federal verification system, he said. He said it to the air in front of him, not to anyone specific, the way you say something when you need to hear it in your own voice before you can process it. Your name, your unit designation. He lowered the sheet. There are 7 commendations on this record. The last one is dated 6 years ago. He looked at her. The record was sealed after that. The official designation is, he stopped. Don't read it out loud, Koss said. From somewhere to Claire's left, close enough that she hadn't heard him approach. Velt closed his mouth. The corridor held them all in a specific, suspended moment, Reese with his portable oxygen unit, Velt with his paper, Stet arriving from one direction, Koss close enough to control what was said, Claire in the middle of all of it with her sleeve up and her watch visible, and 11 weeks of careful construction coming apart around her with the quiet, inevitable quality of something that was always going to end this way. She looked at Velt. He was looking at her as if he was seeing her for the first time, which, she supposed, he was. There's a conversation we need to have, she said. But Reese needs to be in his bay. His cardiovascular window is under 90 minutes. And if someone doesn't reconnect his supplemental oxygen in the next 4 minutes, and we're going to have a different conversation instead. Velt blinked. The department reasserted itself around him, the alarm, the monitors, the weight of 5 patients in 5 bays. And he straightened and looked at Okafor, who had appeared behind him. Get Commander Reese back to Bay 5 and reconnect his oxygen. Okafor moved. Reese looked at Claire for one more second. He was not asking for anything. He was not asking her to explain or confirm or account for herself. He was looking at her the way someone looks at a person they are in the process of understanding correctly, and the understanding was not simple or comfortable, but it was real. Then he let Okafor take the portable unit and walk with him back toward Bay 5. Claire turned to face Stet and Koss and Velt, all 3 of them in the corridor with their various papers and credentials and revised understandings of what was standing in front of them. She was about to speak when the overhead alarm changed. Not the oxygen system alarm that was still sounding, the sustained double tone she'd been hearing for the last 20 minutes. This was different. Single, rapid, a different pitch entirely. The fire suppression system. In the medical gas storage room at the end of the corridor, where Ninawald had been connecting backup oxygen tanks for the last 20 minutes, something had malfunctioned. Pression system read the pressurized oxygen environment as a fire risk and activated. And when it activated, it did what it was designed to do. It sealed the storage room and began flooding it with suppression agent, with Wald inside, and with the remaining backup tanks that had not yet been connected to the patient bays. 4 tanks, still in the room, sealed behind a door that had just been locked automatically by a system that didn't know or care that the people in the corridor outside it needed what was behind it. Claire was already running before anyone else had finished processing what the new alarm meant, and behind her she heard Koss moving too, and somewhere further back, Velt and the whole terrible arithmetic of the situation assembled itself in her mind as she covered the distance to the end of the corridor. 4 tanks behind a sealed door, 3 patients whose oxygen allocation was not yet secured, pressions system that would take 11 minutes to cycle, and a window for Riss's cardiovascular event that was now under 85 minutes and shrinking. She hit the storage room door at full speed. It didn't move. She hit the emergency panel, beside it a red box with a physical override switch that was supposed to allow manual release in exactly this kind of situation. And the switch did nothing, which meant the seal had engaged before the override circuit had completed its startup sequence, which was a failure mode that existed in the documentation for the system and that someone had apparently decided did not require immediate remediation. She could hear Wald on the other side of the door, not calling for help assessing, counting, doing what a competent person does when they find themselves locked in a room with oxygen tanks and suppression agent, staying calm and figuring out the options. Nina, Claire said, loud enough to carry through the door.
Are you hurt?
No. The agent hit the tanks. They're sealed. They're not venting. I don't think there's a reaction risk. But I can't get the door. We're working on it. She turned. Koss was behind her. The override failed. Is there a facility manager? A maintenance emergency line. Stett is calling it, he said. How long? He didn't answer, which told her longer than she wanted. She turned back to the door. The seal was magnetic. She could see the electromagnetic housing on the frame edge. Magnetic seals required power to maintain. If the power to that specific circuit was interrupted, the seal would release. She looked at the panel beside the door. At the wiring housing. The circuit breaker, sub-panel mounted on the wall, 6 feet away. She looked at Koss. Do you have anything that can interrupt a circuit without destroying the panel? He looked at her for half a second. Then he reached into his jacket. And from inside the storage room, through the door, she heard Wald's voice change quality, from calm to the specific, controlled urgency of someone who has just noticed something that changes the calculation. Claire, Wald said. One of the tanks. The valve, it's not, I think the suppression agent reaction is, then a sound. Not an explosion, something sharper and smaller. A seal giving way under pressure. The specific crack of a valve fitting, failing under conditions it wasn't rated for. And then silence from inside the room. The silence from inside the storage room lasted 4 seconds. Then Wald's voice came back thin, strained, but present. I'm okay. The valve fitting blew, but the tank sealed. There's oxygen venting into the room, but I'm okay. Claire's hand was already on the sub-panel beside the door. She'd identified the circuit breaker that controlled the magnetic seal housing while Wald was still talking. And she pulled it without ceremony, a clean, manual interrupt, the kind of thing that was technically against building protocol and absolutely the right call. The electromagnetic hum in the door frame went silent. The seal released with a thud. Koss pulled the door open. Wald was standing in the middle of the storage room with one hand pressed against the wall and the other gripping a shelving unit, her face the particular gray-white of someone managing a spike of adrenaline through sheer professional stubbornness. The tank, whose valve fitting had failed, was on the floor, still upright, oxygen hissing from the damaged fitting in a thin, audible stream. The suppression agent, fine dry powder, coated the floor, and 2 of the remaining tanks in a white film. Tanks that were sprayed, Claire said. Are the valves intact? Wald checked. Her hands were shaking slightly. She ran her palm over the valve housing of the nearest tank, checking for damage by touch. They look intact. The agent hit the surfaces, not the mechanisms. Can you connect them? Give me 2 minutes. You have 90 seconds, Claire said. And then I need you out of that room before any of us have a longer conversation with the facilities team about the override failure. Wald made a sound that was not quite a laugh and started connecting tanks. Claire turned back to the corridor. The suppression alarm was still running. The oxygen system alarm was still running. The combined noise was the soundtrack of a department in controlled crisis, and it had been playing for long enough that the staff had begun to adapt to it the way you adapt to persistent discomfort, not ignoring it, but functioning around it, which was the only viable option. Koss was standing at her shoulder. Behind him, Stett, who had concluded her call and was watching the storage room situation with the expression of someone cataloging everything for a report she was already composing in her head. The override failure, Stett said. That's a building systems issue. Yes, Claire said. It shouldn't have happened. No, it shouldn't have. She looked at Stett directly. The oxygen feed failure also shouldn't have happened. In a trauma department with 5 critical military patients, both of those failures happening the same morning requires an explanation that has nothing to do with coincidence. Something sharpened in Stett's expression. You think it wasn't a malfunction. I think 2 independent safety systems failing in the same 4-hour window, in the same department, during an active classified exposure event, is a question that someone needs to ask formally. I'm asking it informally right now because I don't have time for the formal version. Stett looked at Koss. The look lasted 1 second and carried the weight of a longer conversation. "I'll make a call," Koss said. He stepped away. Claire watched him go, then looked at the wall panel that still showed the oxygen feed pressure low, but not critical now. When the backup tanks Wald was connecting, beginning to register on the building system. Stabilization was real, but temporary. The main feed needed to be restored, and that required the facilities team, and the facilities team needed to be somewhere other than wherever they currently were. Velt appeared from the direction of the central station. He had the second printout still in his hand, and he'd had long enough now to process what was on it, which meant the expression he was wearing was no longer the raw, unguarded surprise of first reading. It had settled psychologically, professionally. It had settled into something more complex, a man working through the specific discomfort of understanding that his assumptions have been wrong and that the wrongness has had consequences. "The maintenance team," he said. "I've been trying to reach Harlow's head of facilities for the last 20 minutes. He's not answering." "Who is the head of facilities?" "A man named Gordon Pruitt. He's been in the role for 4 years. Velt paused. "He reports to the hospital's chief operating officer." "Who is?" "Diane Solt." Velt said the name with a flatness that told her the name had become recently significant. "She's been CO for 7 years. She has full administrative authority over operational and maintenance budgets, including the safety system's maintenance contracts." Claire looked at him. The oxygen feed failure and the override malfunction both fall under safety systems maintenance. "Yes." "Has the maintenance on those systems been flagged as overdue?" Velt's jaw tightened fractionally. "There have been internal reports. I've seen the summaries in the department compliance emails. I didn't pursue them beyond the committee level." He stopped. The reports were routed through Solt's office. The responses indicated the maintenance was scheduled and on track. It wasn't. It appears not. The suppression alarm stopped. The oxygen system alarm continued for another 8 seconds, then also went silent. Wald had finished connecting the tanks. The pressure in the backup system had reached the threshold required for the alarm to clear. The sudden relative quiet of the department felt like a different kind of pressure. "Gordon Pruitt," Claire said. "Has he been in the building today?" "He signed in this morning. His office is on the 2nd floor. Is he there now?" "His assistant says he's in a meeting." "Where?" Velt looked at her. "Solt's office." She turned to find Stett, who was now on her own phone near the supply room entrance. "Colonel, the COSU of this hospital and the head of facilities are currently in a meeting together. Given the questions about the safety system failures, I'd recommend those 2 people be in separate rooms very shortly." Stett lowered her phone and looked at her with the expression of someone who has just received information that confirms a direction she was already moving. "I have someone who can make that happen." "Quietly," Claire said. "If they know it's coming, anything that could explain what happened to those systems becomes significantly harder to find." "I understand how these things work," Stett said. There was no edge in it, just the flat acknowledgement of a professional speaking to another professional about mutual competence. Claire went back to the patients. The next 40 minutes were the hardest. Not because the clinical situation deteriorated dramatically, it didn't. Not in the way the morning had repeatedly threatened, but because sustained precision under sustained pressure is a different kind of exhausting than acute crisis, and she had been doing it since 7/26A, without a break and without anything approximating certainty that the framework she'd built from a memory and clinical judgment and a working knowledge of a compound that officially didn't exist was going to hold long enough to matter. Reese's cardiovascular window opened at 1:34 p.m. She was already in the bay. She had been in the bay for 12 minutes by the time the first monitor change appeared, because she'd calculated the window and positioned herself accordingly, rather than waiting for the alarm to summon her. Ulmer was there too. The cardiologist had taken Claire's instruction about Bay 5 seriously and had established a working presence in the room rather than a standby position down the corridor. The rhythm change was subtle at first, a slight prolongation in the QT interval that was visible on the monitor to someone who knew to look for it and invisible to someone who didn't. Claire saw it and said, "There." And Ulmer looked at the trace and said nothing for a moment, and then said, "How did you know exactly when?" Compound's cardiovascular stage follows the coagulation and neural stages by a consistent interval in high-tolerance patients. I've been tracking his overall timing since this morning. From a single exposure event. Yes. Ulmer considered this information in the compressed way of a specialist who is in the middle of a clinical situation and cannot afford the time the information actually deserves. "What do you need?" Claire told her. The intervention was layered a primary agent for the conduction issue, a secondary for the vascular component that would follow approximately 20 minutes later, and a monitoring parameter adjustment that would let them catch the transition between the two phases without waiting for the monitor to alarm. She gave Ulmer the specific doses and the specific timing, and Ulmer administered them with the focused efficiency of someone who has decided to trust a source and is going to do it correctly or not at all. Reese was awake through all of it, watching, managing his own discomfort with the same practice suppression he'd applied all day, though with less reserve. Now the window was real, and his body was experiencing it in a way that his training could only partially address. You knew this was coming since this morning," he said, at a point between first and second intervention, when there was a brief, held stillness in the room. "Yes. And you managed the whole department while keeping a timeline on all 5 of us." "I did my job." He was quiet for a moment. His rhythm on the monitor was holding not clean, not perfect, but holding in the way that mattered. "In Sector 12, he said, the medic who held the perimeter. She had a broken radio. She coordinated the extraction using a signaling method that wasn't in any protocol. The debrief report couldn't fully account for how she knew what she knew in that situation." Claire kept her eyes on the monitor. "The report listed her as KIA because she didn't come out with the team," he said. "There was no body." That detail was in the classified annex, not the main report. Most people with clearance never read the annex. "Commander," she said, "your QT interval." He looked at the monitor. Then he was quiet and let her work. The second intervention went in at the 22-minute mark. His rhythm stabilized over the following 8 minutes in a way that was genuine rather than pharmaceutical. The conduction pathway reasserting itself as the compound's chemical interference was countered at the molecular level by agents that had been selected specifically for this purpose. His blood pressure came back up. His color improved by a visible degree. His hands, when she checked his grip strength as neuroassessment, were steady. Ulmer made a notation on his chart and looked at Claire. "All 5 of them," she said. "You managed the pharmacological intervention on all 5, from a compound with no clinical database entry, in sequence, without losing any of them." "Ferris's VTAC was close," Claire said. "Yes, but you converted it." Ulmer paused. "I've been in cardiology for 19 years. I would not have known to use that agent at that dose for that rhythm presentation. Not for this compound. Not without a reference. I had a reference." "Where?" Claire looked at her steadily. "Somewhere I'm going to have to explain to several people in the next few hours." She looked at Reese. "When you're ready to be left with Dr. Ulmer for monitoring, I need to step out." "Go," he said. "I'm not going anywhere." She almost smiled. It was the first time all day she'd come close. She left Bay 5 and found that the corridor outside had changed while she'd been inside. Perimeter of the department had quietly acquired additional people, 2 more individuals, with the federal bearing she'd come to recognize. A Harlow security staff member standing at the main entrance with the uncertain expression of someone who has been told to stand there by a person with credentials they couldn't argue with, and near the central station. Conversation that was not going well for one of its participants. The conversation involved Velt, Stet, Koss, and a man she hadn't seen before, mid-50s, heavy build. The defensive posture of someone who has been interrupted in the middle of something they didn't expect to be interrupted in. Gordon Pruitt, she assumed, who had been in a meeting with Diane Solt and was now not in that meeting anymore. She walked toward them, not quickly, and stopped at the edge of the group. Pruitt was sweating, not from temperature. Not from temperature. He had the particular perspiration of a man whose body has registered that the situation is worse than his mind is ready to admit. The maintenance records were filed correctly, he was saying. The schedule was on track. The oxygen feed valve failed this morning, Velt said. His voice was flat in a way that was different from his administrative flatness. This was the flatness of someone who has spent the morning revising their understanding of how their department has been managed and is not handling the revision well. The fire suppression override circuit failed. Both failures are in systems that had open maintenance tickets that were marked as resolved in the records. The physical systems indicate they were not resolved. Equipment fails. The tickets were closed, without work orders attached, Stett said. I've had someone from my office pull the maintenance records from the last 18 months. 14 tickets across the oxygen and suppression systems, all marked resolved, 11 of them without work orders. She let that land. Where did the maintenance budget go, Mr. Pruitt? His jaw moved. He looked at the floor, the look of a man doing rapid calculations about how many exits remain open to him. I want to speak with legal counsel, he said. You can do that, Stett said, after you tell me whether Diane Solt was aware of the discrepancy, or whether she directed it. Silence, long enough to be its own answer. I want counsel, he said again. Noted, Koss said. He signaled to one of the additional federal staff, who moved forward. Pruitt didn't resist. He had the collapsing posture of a man who has been waiting at some level for this specific moment, who has known it was coming, and has been managing the dread of it rather than planning an actual response. He was walked to a side room. The door closed. Velt watched it close. Then he turned and found Claire standing nearby, and the look he gave her was not one she'd seen from him before, not the administrative dismissal of the morning, not the reluctant revision of the afternoon, but something closer to the undefended attention of a man who is done pretending he has the full picture. Solt, he said. Was she involved in the accident itself? The offshore event? I don't know, Claire said honestly. Koss and Stett are better positioned to answer that. What I can tell you is that the safety system failures today weren't random. Whether they were related to the compound exposure or opportunistic, I don't know. They happened in the worst possible window for the worst possible reasons. Patients. All 5 of them. He paused. They're going to survive. I believe so. Reese just came through his cardiovascular window. Patient 1 is post-surgical and holding. Ferris is in monitoring after VTAC conversion. Loon's lung is re-expanding with the adjusted protocol. Reeves' neuropresentation is being managed, and the CT showed no structural event, just chemical disruption. Velt was quiet for a moment. Around them, the department moved monitors, staff, the sound of a functioning trauma center that had spent the last 6 hours being something much harder than that. I misjudged you, he said. She'd known it was coming. She had, in the back of her mind, been composing a response to it since sometime around 9 a.m. Now that it arrived, she found the response she'd prepared was not the one she wanted to give. You didn't have enough information, she said. Neither did I, about everything I would need to know today. We both worked with what we had. It was more generous than he'd earned, and she knew it, and she gave it anyway, because she was tired and because what she wanted was not satisfaction at his accounting, but to finish a very long day and be certain 5 people were still alive at the end of it. He nodded. He didn't push for more, which she appreciated. Koss appeared at her shoulder. Solt is in her office. My team is with her. She's not going anywhere. He paused. She's asking for the hospital board's legal representative, which tells us something about what she thinks we know. What do you know? Claire said. The offshore accident site. Company that operated the installation was a contractor with DoD affiliations. Solt had a consulting relationship with that contractor going back 4 years. He kept his voice low and level. The safety maintenance budget, the money that was supposed to go to those tickets, was rerouted through a facilities subcontract. The subcontract company is a shell. We've been looking at it for 8 months for a different reason. Compound, Claire said. Was it being developed there? At the offshore installation? We believe so. Unofficially. He looked at her steadily. The accident may not have been an accident. We think someone shut down a safety containment system. We think it was done to destroy evidence. The 5 men got caught in it. Claire absorbed this. She thought of Reese in Bay 5, of Ferris, who had nearly died at 180 beats per minute, of Reeve, who had decided other people's emergencies mattered more than his own, of Lund breathing more easily now than he had, since morning, of patient 1, who was sleeping off surgery in a post-op room and didn't know yet how close he had come. Person who shut down the containment system, she said. Do you know who it was? We have a strong candidate. The investigation is. Koss stopped. His phone vibrated. He looked at it. His expression didn't change in any dramatic way, but the specific quality of his stillness shifted. What? She said. Solt's legal representative just arrived at the hospital, he said. 40 minutes faster than should have been possible given when she made the call. He was already on his way. Yes. She knew you were coming. She knew something was coming. He put the phone in his pocket. Question is how much she knew and how early she knew it. He looked at Claire and whether the safety system failures today were meant to be survivable. The implication settled. She let it. You think they were meant to kill the patients, she said, before anyone could talk to them about what they saw at the installation. I think it's possible. He paused. I think if the patients hadn't had someone here who knew exactly what the compound would do and exactly how to manage it, the failures might have been enough. She stood with that for a moment. In Bay 5, behind a closed door, Reese was being monitored by Ulmer and the cardiology team. In Bay 3, Ferris was in sinus rhythm. In Bay 2, Lund was breathing. In Bay 4, Reeve was watching the ceiling and waiting for someone to tell him the headache was going to stop. They were alive, improbably, marginally, because of 6 hours of sustained work. It was a specific work and the specific knowledge she carried, and had spent 2 years hiding in a civilian life that had just become fully unsustainable. They were alive. The full conversation, she said to Koss. The one I've been putting off. Yes, it needs to happen today. I know. I want Stett in the room, and I want Reese there if he's stable enough. He has the right to understand what was done to his team. Koss considered this. That's irregular. A lot of today has been irregular. He considered it for another moment. Then, when Reese is cleared by cardiology, give me an hour, she said. She went back to work. In that hour, 3 things happened in sequence that each mattered. The first, Okafor found her at the central station and stood beside her without speaking for a moment, which was itself unusual enough that she looked at him. I dismissed 4 of your flags this morning, before you were proven right, he said. I want to say that directly. She looked at him. He was 28 years old, and he was going to be a good physician if he didn't spend the next decade letting the hierarchy teach him to stop questioning it. You responded when it counted, she said. That's what matters. It's not all that matters. No, she agreed. But it's not nothing. He nodded. He went back to his station. It wasn't absolution, and she hadn't offered it as such, but it was the beginning of something, the kind of reckoning a person can actually learn from, rather than just feel bad about. The second, Dr. Price came to find her outside Bay 1 and told her that patient 1's post-op blood work showed the compound markers declining on the treatment protocol. The first hard evidence that the staged management approach was working, systemically, not just managing acute presentations. Claire took the printout Price offered, looked at the numbers, and felt something in her chest release that had been held tight since she'd first caught the smell at the ambulance bay doors. It's working, Price said. Not a question. Yes. How long until they're clear? 48 to 72 hours for full metabolic clearance. Assuming no additional complications, all 5 should be off supplemental oxygen within 24 hours. Price looked at the printout in Claire's hands. The protocol you built, I'd like to document it formally, with proper attribution. Talk to Koss and Stett before you document anything, Claire said. Some of the pharmacological specifics have classification implications, but the clinical framework, the staging approach, the sequenced intervention model, that should be in the literature. It should have been in the literature a long time ago. Price looked at her steadily. I know. I'm sorry it wasn't. The third thing was the one that changed everything again. Just when she'd thought the shape of the day was finally resolving. 3:12 p.m. While she was reviewing Reese's most recent vitals with Ulmer and beginning to believe that the worst was genuinely over, Koss came into Bay 5 with a physical folder in his handpaper, which meant it was something he didn't trust to a screen in a room with uncertain security. He gave it to her. The folder contained a single document. 8 pages, government formatting, classification markings she recognized from a different period of her life. She read the first 2 pages without speaking. Then she stopped and looked at Koss. This is the original after-action report, she said. The Sector 12 extraction. Yes. The version with the classified annex. Yes. She looked at the document again. At the section that covered the 12 minutes she had spent alone at the perimeter, at the accounting of what she had done in those 12 minutes and why. In those 12 minutes and why, at the recommendation section that appeared at the bottom of the 4th page. At the signature on the recommendation, she looked up at Koss. He signed it, she said. Psst. He wrote the commendation recommendation, and then he filed the KIA designation. The commendation was never processed, Koss said. The KIA designation was filed 4 days later. Different office, different chain. He paused. We believe the filing was deliberate. We believe it was done to remove you from the record before the commendation created an official trace. Why? She said. Even as she said it, she was already assembling the answer from pieces she had, pieces she'd carried without fully connecting for 2 years. Because what you saw at the site before the extraction, before Sector 12, Koss's voice was steady and careful. You saw something that was connected to what's in the beds down the hall. Compound, the testing program. He looked at her. You saw it before most people knew it existed. And someone decided that was a problem. She looked at the signature on the recommendation. She looked at it for a long time. The name was familiar. She had worked with him. She had trusted him. She had not seen him in 2 years, which she had attributed to the sealed record and the KIA designation and the clean slate civilian life she'd built around the absence of her own history. She looked at Koss. Is he connected to Solt? To the offshore installation? We're still pulling threads, Koss said. But the shell company, the subcontract that absorbed the maintenance budget. He paused. One of the signatory names on the incorporation documents. He didn't finish the sentence. He didn't need to. She looked at the signature one more time. The name of the man who had written her commendation and then buried her under a KIA designation. And then, she now understood, had spent 2 years connected to the same network that had just tried to kill 5 people in trauma department that she happened to be working in. Reese spoke from the bed. He had been listening. Of course, he had been listening. And his voice, when he spoke, was the controlled, flat voice of a man absorbing information, with the focused attention of for whom this information is operational. Who is it? He said. She looked at him, at the folder in her hands, at the name that was sitting there in government typeface, permanent and undeniable, on the recommendation that had been filed and then buried in the same motion. She turned the folder so he could see the page. She watched his face when he read the name, and the expression that crossed it was not the surprise she'd expected, which told her that he'd been assembling his own version of this picture from his own pieces, and that what he was looking at now was not a revelation, but a confirmation, the last piece of a pattern he'd been seeing the shape of for longer than today, longer than the offshore accident, perhaps longer than he'd been willing to say out loud. He looked up at her. He's still active, Reese said. He has an office. He has clearance. Yes, Koss said. And he knew we were going to that installation. The question landed in the room with the weight of something that had been waiting to be asked since the first ambulance pulled into Harlow's Bay at 7:26 a.m. Koss said nothing, which was the same as saying yes. The name on the folder was Brigadier General Warren Holt. Reese said it aloud, once, quiet, as if hearing it in his own voice made it more real than reading it had. Then he didn't say it again. He handed the folder back to Claire with the deliberate steadiness of a man who has converted shock into something more useful, not anger, not yet. But the cold, focused attention that precedes a decision. He assigned us to that installation, Reese said. The mission tasking came through his office. He was the one who said the site was secure. We know, Koss said. He knew it wasn't. We believe so. Reese looked at the ceiling for a moment, his cardiac rhythm on the monitor. Behind him was steady 78, clean, the ordered electrical language of a heart that had come through its crisis, and was now doing the ordinary work of keeping a man alive while he processed extraordinary things. He sent 5 of my people into a containment site that was being prepared for destruction, he said. And then the hospital, those 5 people were taken, 2 had 2 safety systems fail on the scene. Yes, that's not coincidence. No, Koss said. It's not. Claire was still holding the folder. She was looking at the recommendation on the 4th page, the commendation, that Holt had written for her 6 years ago and then ensured was never processed. The official praise for 11 minutes of work that he had subsequently buried under a KAA designation, because the work she'd done that day had given her knowledge that was inconvenient to a program he was protecting. She had spent 2 years rebuilding her life from scratch around the assumption that someone powerful had decided she was easier to manage as a ghost. She had not known until 40 minutes ago that the someone was him. Closed the folder. Where is he now? She said. Washington, Koss said. He was notified of the offshore incident this morning through official channels. He's been in contact with his office throughout the day. A pause. He doesn't know we have the incorporation documents. He doesn't know we've connected the shell company. He doesn't know you have this folder. He knows the after-action report exists. He doesn't know this version of it surfaced. She looked at him. When you say surfaced, the classified annex was filed separately from the main report. Different archive, different access level. We found it 8 weeks ago during the broader investigation into the offshore contractor. Your name appears in it. Koss kept his voice even. We've been trying to locate you for 6 weeks. You're very good at not being found. I had a reason to be. You did, he said. We know that now. Ulmer was standing quietly near the monitor station, giving the conversation, exciting the conversation space it needed, while remaining close enough to intervene if Reese's readings changed. She was not a person who performed discretion. She simply practiced it, which was different and more useful. Caught Claire's eye briefly and gave her a small, professional nod that communicated the one thing that mattered. He's stable? You have time. Claire set the folder on the chair beside Reese's bed. The documentation on Holt the Incorporation signatures, the archived annex, the connection to Solt. Is it enough? Enough for what? For it to go somewhere permanent. Not a suspension, not an administrative review. Something that doesn't get buried again. Koss looked at her for a moment, with the patient testimony from all 5 operators about what they saw at the installation. Yes. With your statement about the compound, the staging knowledge, the source of your familiarity. Yes. With the annex and the incorporation documents together, he paused. Yes. It's enough. Then let's do it today, she said. While everyone is in this building and everyone's account is fresh and no one has had time to coordinate a different version of events. 3:41 p.m. The day had been going for 8 hours and 15 minutes. She was tired in the specific way that had nothing to do with sleep and everything to do with the sustained expenditure of every form of attention she had, held at full capacity for longer than was reasonable, and she was going to have to hold it for a few hours more. She could do that. She had done harder things in worse conditions, with less at stake. The difference was that those things had been done in the service of an institution and a chain of command that had subsequently decided she was inconvenient. This was different. This was 5 people she had kept alive by knowing exactly who she was and refusing to pretend otherwise when it mattered, and she was going to see it through to the end that they deserved. She walked out of Bay 5 and went to find Stett. Formal session happened in Harlow's 3rd-floor conference room at 4:15 p.m. It was not a deposition in the legal sense that would come later, in with proper counsel and the kind of recorded formality that proceedings required. What it was, practically, was a structured briefing involving Stett, Koss, two additional federal investigators, Velt and Claire, during which she gave a full account of her knowledge of the compound, its origins, its staging mechanism, and the source of her familiarity with it. She spoke for 40 minutes without notes, because the notes were in her head in a place where they had been stored for with particular permanence of things learned or conditions where forgotten was not an option. She described the classified testing program she had been assigned to as a combat medic, the nature of the compound's development, the exposure event she had witnessed that formed the basis of her understanding of the staging sequence. She described what she had seen in Sector 12 before the extraction, the secondary site, the documentation she had seen before they were compromised, the 11 minutes at the perimeter that had given her more direct observational data than she had been supposed to accumulate. She described the KIA filing and the 2 years of deliberate disappearance that had followed, and she did it without editorializing, without anger, in the same level, specific voice she'd used all day to describe clinical findings, because the facts were sufficient without embellishment, and she was not interested in performing her own injury for an audience. When she finished, the room was quiet for a moment. Then Stett said the commendation recommendation that Holt filed and subsequently suppressed. Do you want it processed? Claire had thought about this. She'd had 40 minutes to think about it while the logistics of the meeting were being arranged, and she had reached a conclusion that surprised her slightly by being so clear. Yes, she said, not for the recognition, for the record, because what happened should be in the record accurately, and right now, it isn't. Stett wrote something on the pad in front of her. We'll initiate the restoration process today. And the KIA designation? Rescinded, effective today. Correction will be filed through the same channels that were used to create it. Claire nodded. She didn't feel the relief she might have expected. What she felt was more like the quiet, necessary settling of something that had been sitting at an angle for a long time, finally placed correctly. She left the conference room and went back downstairs to her patients. Holt's world came apart in the next 18 hours, and it came apart publicly, which was the part that mattered. Stett's team moved simultaneously on 3 fronts. In the late afternoon, the shell company's financial records, the communications between Holt's office and the offshore contractor. In the weeks preceding the incident, and the testimony of Gordon Pruitt, who once separated from Solt. And confronted with the paper trail, Maddox still demonstrated the specific moral pragmatism of a man who has decided that cooperation is preferable to primary culpability. He talked for 4 hours. The investigators took notes and gave him water and let him keep talking. Solt lasted longer. She had a better attorney and a more practiced relationship with institutional self-protection, and she spent the late afternoon hours deploying both with the focused energy of who still believes a good argument can change the mathematical reality of documented evidence. It couldn't. The rerouted maintenance budget was traceable to the day and the dollar. Her consulting relationship with the contractor was documented in her own emails. The speed with which her attorney had arrived at Harlow 40 minutes before he should have been able to, from an office that required at minimum 90 minutes of travel, was itself a data point about prior coordination that required explaining, and the explanation she offered did not survive contact with her phone records. By 6 a.m. the following morning, both Solt and Pruitt had been formally referred for criminal investigation. The hospital board, convened in an emergency session that evening, placed Solt on immediate administrative suspension pending the investigation's outcome and retained an independent firm to conduct a full audit of Harlow's safety systems maintenance contracts for the preceding 4 years. Holt's situation was more complex, as situations involving general officers always were, layered in classification and institutional protection and the practiced resilience of people who have spent sixes inside systems that protect their own. But the annex was real. The incorporation documents were real. Riss's testimony, delivered from a hospital bed in a recorded session with Stett's team at 7 p.m., The evening of the incident, while his cardiac monitor ticked along steadily in the background, was detailed, specific, and devastating. He had the memory of a man trained to observe and retain, and he described everything he and his had seen at the offshore installation with the same flat, precise economy he'd applied to every conversation Claire had watched him have. The other 4 operators, each interviewed as their conditions permitted across the following day, added their own accounts. Ferris, who was the most verbal of the group, when he finally decided to speak, gave an account that included specific visual details about the installation's interior that corroborated a critical section of the documentation recovered by Stett's team. Reeve, interviewed while still nursing the residual effects of the neurological disruption, described what he had observed in the 20 minutes before the accident with the focused, sequential precision of someone who had been trained to report accurately in adverse conditions and was applying that training even while his head hurt and his vision occasionally flickered at the edges. Holt was placed on administrative hold, pending investigation at 9 a.m. the morning after the incident. His security clearance was suspended at noon. By the following week, the formal charges had been drafted, and the people drafting them had enough to make them stick. It was not fast. It was not clean. There were lawyers and classified evidence protocols and interagency, jurisdictional complications that generated paper and meetings and delays that were genuinely frustrating to everyone who had been in that trauma department on the day in. Questioned and understood exactly what had nearly happened. Justice in institutions moves at institutional speed, which is not the speed of emergency medicines, and Claire had known that going in. She had known that the accountability would be real but slow, and she had made her peace with slow because the alternative was nothing. She was still at Harlow when the first formal charge was filed. She had not expected to be. She had walked into the building 11 weeks ago with a provisional plan that involved a clean civilian life at a safe remove from everything she'd been before, and that plan had lasted until 7:26 a.m. on the morning 5 men arrived, smelling of a compound she recognized. Plan was gone now, comprehensively, irreversibly gone, and in its place was something she hadn't known how to want while she was in the process of hiding from her own history. Purpose that didn't require her to pretend she was someone other than who she was. In the 2 weeks following the incident, Harlow changed in ways that were structural, and ways that were harder to name. The structural changes were visible and traceable. The hospital board commissioned the full safety audit and acted on its findings. 7 maintenance contracts were terminated. 3 were renegotiated with independent oversight requirements, and a new facilities director was appointed with a mandate that included monthly reporting directly to the board rather than through the COO's office. The oxygen system was repaired properly, the override circuits were tested and certified, and the results were documented with work orders that were real and attached and verifiable. The trauma department's protocols were reviewed. This was Velt's initiative, and he undertook it with the particular energy of a person doing penance through work, which Claire recognized and did not comment on because the outcome was useful regardless of the motivation. The review incorporated the staging-based assessment framework she had applied during the incident, the principle of treating the patient's observable presentation as primary information rather than waiting for the monitor to confirm what a skilled clinician could already see. It was not a radical idea. It was the kind of idea that gets lost in institutions where efficiency and standardization are valued above the slow, expensive work of training people to actually look. Okafor incorporated it immediately and visibly in the way of someone who has a significant professional experience and is not going to waste it. He started asking nurses what they were seeing before he looked at the charts. It was a small thing. It changed the texture of the department in ways that were hard to quantify and easy to feel. Farrar submitted a formal case report on the compound's staging mechanism and clinical management to a peer-reviewed journal. She listed Claire as the primary contributor. The journal's review process required extensive redaction of the classified specifics, which Stett's team managed through a formal process that took 3 weeks, and the published version was necessarily incomplete, but the clinical framework, the staging model, the intervention sequencing, those survived the redaction intact and entered the literature in the way that such things should, available to the next person in the next room facing the next version of this situation. Velt apologized twice. The first time was 3 days after the incident. In the trauma department, in front of Okafor and Farrar and 2 of the interns and Nina Wald, who had returned to work the day after, with a bruise on her forearm from the storage room and the quiet resolve of someone who has decided that the experience is going to make her better at the job rather than afraid of it. He apologized to all of them for the culture that had allowed Claire's assessments to be dismissed for as long as they had been, and he did it without excessive self-flagellation and without the kind of performative remorse that turns an apology into a story about the person apologizing rather than the wrong being acknowledged. It was an adequate apology, not a perfect one. The second time was private. He came to find her in the break room on a Thursday afternoon when the department was in a quiet period and said, with the slightly effortful directness of a man practicing a skill he didn't come to naturally, "I want to say this separately. What I told you this morning, that you're a nurse, not a battlefield commander, that was dismissive, and it was wrong, and it contributed to a situation where my patients were at greater risk than they needed to be. I'm not going to pretend it was only about you." She looked at him over her coffee cup. "It wasn't only about you," he said. "It was about who I decided I was allowed to learn from. And I'm working on that." She set down the cup. "I know," she said. "I watched you work on it in real time for 6 hours." He almost smiled. "Not quite. Are you staying?" he said. She had been thinking about this. The clean slate was gone, but the question of what was genuinely crinkly open, that felt different from the constrained, carefully managed openness of the past 2 years. The postmaturskhet. She was no longer hiding. Her record had been corrected. KIA designation was rescinded. The commendation was in process, and the full account of who she was and what she knew and what she had done was now in the hands of people who were using it for purposes she'd chosen rather than purposes that had been assigned to her. Could go back. There were people at the federal and military intersection of things who had made it clear through Koss and Stett and one conversation with a senior officer she hadn't spoken to in 6 years, that there was a place for someone with her specific knowledge and history in ongoing investigation of the compound program and its institutional connections. The work was important. She knew it better than almost anyone alive. She could also stay. For now, she told Velt. Yes. He nodded. He left the break room without pushing for more, which was, she reflected, genuine progress. 5 operators were discharged across a 5-day window in the order of their clinical recovery rather than any other hierarchy. Patient 1, whose name she finally had from the formal case records, was Petty Officer Marcus Drayle, was last because the post-surgical recovery required the additional days, and also because he was the least inclined to stay in a hospital bed and needed the additional medical authority that the discharge delay provided. Loon left on day 2, breathing at 98% saturation, with clear imaging and the instructions for his follow-up care written in language that was precise enough to actually be followed. He shook Wald's hand at the nursing station and said something to her that made her laugh, which was the most human sound the department had produced in several days. Reeves' headache resolved on day 3. His vision cleared. He left on day 4, and he stopped at the central station on his way out and found Claire doing chart entries and stood beside her for a moment without speaking. She looked up. "Thank you," he said, "for counting me." She understood what he meant. "Your emergencies count," she said. "That doesn't change after today." He nodded once, the way young men nod when they are trying to hold on to something they don't have the language for yet, and then he left. Ferris was discharged on day 3. He came to find her before he left, and he was more himself than she'd seen him. The tight economy of his early days in the Bay had relaxed into something less armored, the way people sometimes relax after they've been genuinely afraid and survived it and no longer need to pretend they weren't. The V-TAC, he said. You converted it in under a minute, 48 seconds, she said. I knew what was happening, he said. I've had training on it. I knew exactly what that rhythm meant. He was quiet for a moment. I've never been that scared. I know. You didn't look scared. I was, she said. I just needed the 48 seconds, more than I needed to show it. He looked at her with the expression of someone filing something away in the place where important things are kept. Then he put out his hand. She shook it. If you ever need anything, he said. Go recover, she said. That's what I need. Reese was discharged on day 3. He was the last of the first 4, held one additional day, because Ulmer wanted a full 24 hours of clean cardiac monitoring before she was willing to sign off, and Reese complied with this requirement, with the patience of a man who understood that arguing with someone's medical expertise when they had just kept you alive was a poor use of the social capital you'd accumulated. He came to the trauma floor the morning of his discharge, dressed in civilian clothes, with the watch she had last seen on his chart table in Bay 5. It was not his watch. He held it out to her. She looked at it. Cracked crystal. The NATO strap. The model that hadn't been manufactured in 14 years. That's mine, she said. I know. It was in the Bay 5 cabinet with your other personal items when you moved between patients. I asked Wald to hold it. He kept it extended. You took it off to work. You shouldn't have. To. She took it. She put it on her left wrist, where the strip of lighter skin marked the place it usually lived. And she pushed her sleeve down over it, and then she changed her mind and pushed the sleeve back up. Just a watch. It was also the only thing she'd carried through 2 years of rebuilding that was entirely, unambiguously from the life before, not a credential, not a skill, not a carefully curated fragment of professional history, but a physical object from the time when she had been fully herself and had not yet been required to disappear. She had worn it under her sleeve out of the same instinct that had governed the rest of the clean slate construction. Keep the past below the surface. Keep the surface clean. Don't give anyone a thread that leads anywhere you don't want them to go. She looked at it on her wrist. Then she left her sleeve where it was. Up. You're not going back, Reese said. It was not quite a question. Not to what it was, she said. There's work with Stett's team. Consulting, at least through the investigation. Maybe longer. She paused. And here, for now. For now is a reasonable answer, he said. I've learned to work with reasonable. He was quiet for a moment. The department moved around them, the ordinary, productive noise of a trauma center, doing what trauma centers were supposed to do. 4 classified compounds and failed safety systems, and a week that had reshaped the professional understanding of most of the people working in it. Sector 12, he said. The 11 minutes. You don't have to I need to say it. He looked at her directly. I wrote in my personal debrief that the perimeter held because of the terrain. That was what I put on paper. He paused. I knew it wasn't the terrain. The terrain was bad. I knew it was a person, and I knew the person wasn't confirmed out. And I wrote terrain, because I didn't have another explanation I was authorized to document. He held her gaze. I'm sorry I wrote terrain. She considered that for a moment. The weight of it. The specific quality of an apology for something that had happened 6 years ago in a different world, offered by a man who was still dealing with the physical aftermath of something that had nearly killed him this week, standing in a corridor of a civilian hospital with a discharge folder in his hand. She said, terrain is hard to control, she said. He understood what she was doing with that, not letting him off the hook exactly, but releasing the hook from the floor so the thing could move. Yes, he said. Go recover, she said. You need it more than you're admitting. Story of my career, he said. He put out his hand. She shook it. His grip was firm and slightly less steady than he would have wanted it to be, and neither of them commented on that. Then he left. She stood in the corridor for a moment, in the ordinary noise of the department, with her watch visible on her wrist, and 11 weeks of careful construction entirely behind her, and she let herself be still. The thing about hiding is that it requires constant work. Not dramatic work, not the operatic effort of a person running and concealing and performing an alternate identity, but the small, sustained expenditure of energy that goes into keeping a version of yourself that fits inside a smaller space than you actually occupy. It is work you don't notice you're doing until you stop doing it, and when you stop, the relief is not triumphant. It is quiet. It is the ordinary feeling of a held breath released. She had spent 2 years in a smaller space than herself. She had done it out of necessity, and it had served its purpose, and it was done. Okafor came out of Bay 2 and nearly walked into her. He caught himself, apologized, and then stopped when he saw her expression, or whatever her expression was doing, which she didn't fully know. "You okay?" he said. "Yes," she said. And then, because it was true, and because there was no longer any particular reason to be economical with true things, getting there. He nodded. "Patient in 2 needs a secondary IV check. I was about to go in, but if you want, I'll take it," she said. She went to Bay 2. The patient there was not one of the 5 operators. He was a 41-year-old man who had arrived 40 minutes ago with a suspected wrist fracture from a workplace fall, and he was in no immediate danger and moderate pain and was anxious in the particular way of people who are not accustomed to hospitals and find the environment more frightening than the injury. He looked up when she came in with the expression of someone who doesn't know yet whether help has arrived or another procedure. "I'm just checking your IV," she said. "It'll take 2 minutes." He watched her work. The IV was fine. Okafor had placed it correctly, which was consistent and good. She confirmed it, checked the drip rate, looked at his color, asked him to rate his pain. 6, he said. "Maybe 5 now. It was worse when I came in." "The medication is starting to work," she said. "The imaging should be back in about 20 minutes, and then we'll know exactly what we're dealing with." "Is it bad?" he said. "The wrist. Is it? The imaging will tell us more than I can," she said. "But you're in the right place." He exhaled. It was the exhale of someone releasing a fear they'd been carrying since the moment of the injury, the fear of not knowing, of bad news, of being somewhere medical, and not understanding what any of it meant. It was one of the most human sounds in the world, and she had heard thousands of versions of it, and it had not become ordinary. She had learned somewhere in the years before Harlow that the moment it became ordinary was the moment to stop and assess why. "Thank you," he said. She checked the IV one more time. She made a notation on his chart. She told him the attending would be in within the hour, and that if his pain increased to 8 or above, to press the call button immediately and not wait to see if it resolved. He said he would. She left the bay. The trauma department of Harlow Memorial continued its work around her monitors. Movement, the quiet and the noise alternating in the rhythm of a place that dealt with the worst moments of people's lives and tried, imperfectly and persistently, to make them less bad. It was not glamorous work. It was not work that got acknowledged in the ways that other work got acknowledged. It was the kind of work that happened in the gap between the crisis and the outcome, in the hours when monitors showed stable and the real danger was invisible, and the people who knew how to see it were the people who showed up and looked. She had spent 11 weeks being dismissed in this department. She had spent one day changing it, not because she had revealed herself dramatically, not because she had made a speech or demanded recognition or performed her history for an audience that needed convincing, because 5 people needed someone who knew what she knew, and she had been there, and she had done the work, and the work had been enough. It had always been enough. The problem had never been whether she was capable of it. The problem had been whether the people in the room were capable of seeing past their own assumptions long enough to let her. That was the part that couldn't be fixed by credentials, couldn't be fixed by title or seniority or the kind of institutional authority that came from being the person who had always been listened to. It required a different kind of fix the slow, difficult work of building environments where the most important person in the room was allowed to be whoever actually had the answer, regardless of where they were standing in the hierarchy. Harlow was starting that work. It would not finish it quickly. It would not finish it perfectly. There would be days, when the old patterns reasserted themselves, when the person with the least institutional power in the room had the most critical information and had to fight to have it heard, and those days would require the same thing. This day had required someone willing to keep saying it, to stay at the bedside, to not leave when dismissed, to outlast the dismissal with the sheer persistent weight of being right. She could help with that. She was good at persistent. 6 weeks after the incident, on a Tuesday morning when the rain had finally broken and Seattle was doing what it occasionally did in early autumn, producing an hour of sharp, clear light between one weather system and the next, Claire arrived at the trauma department at 6:55 a.m. and found a meeting in progress at the central station. Velt was presenting the revised protocol framework to a group that included the trauma nursing staff, 3 residents, and 2 attendings from adjacent departments who had requested inclusion. Ulmer was there, which was not standard. Price was there, which was not standard either. Farrar was presenting a section on the compound case study with the composed present of someone who had learned something important and intended to make sure the learning transferred. Claire took her position at the medication station and began the morning's chart review. Velt saw her arrive. He continued the presentation. He did not stop to acknowledge her, which was correct. She was early and the meeting was in progress and the work of the morning needed to move. But at the moment when Farrar reached the section of the case study that described the staged management protocol and its origins, Velt looked across the department to where Claire was standing and gave a single brief nod. Not an apology this time, not an acknowledgement in the public, performative sense that turns someone else's competence into a demonstration of the acknowledger's growth. Just a nod. One professional to another, across a room that both of them were responsible for making work. She went back to the charts. Her watch was visible on her wrist. Cracked crystal caught the early light from the windows, in the way it always had, not perfectly, because nothing cracked was ever perfect, but clearly in the way of something that had survived enough to know what it was made of. She had a patient in Bay 3 who needed a medication adjustment before the morning attending came through. She had a new intake at 7:15 that Wald had flagged as potentially complex. She had a department that was slowly, imperfectly, in the way of all real institutions, doing real work, becoming better at seeing the people it was supposed to serve, including the people doing the serving. She had, after 2 years of being a ghost and 1 day of being undeniable, a reason to stay. 3 chart and walk toward the door. Some people spend their whole lives being told they are less than they are. They adjust to the space they're given. They learn to hold their expertise quietly, to move carefully, to take up less room than they need. And then one day, in one room, the situation becomes what only they can handle. And the question is not whether they are capable. The question is whether, after everything, they can still choose to step forward. Claire Dawes pushed open the Bay 3 door and stepped through it without hesitation. She always had been. Has been.